And now we start with the afternoon section. And I invited Dr. Vincenzi. I hope that is connected. Dr. Vincenzi is not ready. Dr. Coletta from Florence.
Good afternoon, Prof. Lima.
Okay.
Hi, Riccardo.
Good afternoon, Prof. Ricciveditoni. Nice to see you.
If you are ready, we start with you.
Thank you so much.
If you want to share your video.
I hope you can see my video that is going to go in.
Okay, there is the title of your presentation and we start. Thank you very much.
Good afternoon to everyone. And first of all, I would like to say thank you to Professor Limia for this invitation. And today I'm going to share with you our most recent case where we use one of the most recent technology. As we know, as we heard this morning, the inflammatory bowel disease is broadly exploding in the whole world. The incidence is getting bigger and bigger, and therefore it's going to be a huge economical burden also for the health system. And if we put our attention in the pediatric field, one of our recent publications in gastroenterology in 2022 showed that 100% of study, 7/7, report an increased prevalence, and most importantly, 31/37 study report an increased incidence of inflammatory bowel disease in pediatric population. And we went to deeply see this publication, even the age are getting lower and lower. Another most interesting publication in 2022 for an Iranian group that they went to understand retrospectively their experience with Crohn's disease. In 16 years, they found 93 patients with a mean age of 10.3 years, with an inflammatory type that raised up to 23.2% in stricturing, and all these patients developed growth delay, low albumin level, but most importantly, in the long-term outcome, 21.5% of these patients need multiple procedures. And this is very important because even this morning I've been told that multiple procedures in Crohn's disease can lead to reduction in bowel length and can be a huge problem. And in fact, even in our recent experience in our last 5 years, we saw an increased number of these patients. In our center, for example, we had a multidisciplinary team with the gastroenterology, surgical team, pediatric surgical team, most importantly, adult surgical team. And as you can see, the mean age of surgery for Crohn's disease now is 15.93 years. And even for ulcerative colitis, the mean age is 15 years. And just for reflection, fibrotic Crohn's disease, as we heard this morning, can develop obstructive symptoms, can lead to surgical treatment, but most importantly, can lead more than one treatment. And we need to keep in mind that up to 60% of Crohn's disease patients need at least one surgical resection in a period of time within 10-year life, and we should avoid extensive resection. In 2013, in Gut, they were published a pathway, and this pathway focused a lot when do surgery. And they develop active disease and non-sign of active disease. And when there is no sign of active disease, we must understand where is the disease. If it's in the small bowel, if it's in the colonic area, or in the area of a previous anastomotic procedure. And as you can see, after that, they suggest a length, 4 centimeters of length. And based on this length, we can do resection, or we can do stricturoplasty. That will be the topic of today. We know several procedures for stricturoplasty. The two most important are the animalculites and the fillet, but both of these procedures need a very short length of bowel. So what we can do when we have an extensive stenotic bowel. And this was the challenge, how Michelassi challenged the community. In 1998, Mr. Michelassi started to challenge the idea that stricturoplasty was only for a short length of stricture, and therefore length is not a variable. And most importantly, it started to challenge the community. We can do the stricturoplasty even where is the active disease. And then he suggests a side-to-side isoperistaltic stricturoplasty. How is it performed? We can find a long center of stenotic ileum. We divide this piece of bowel. We perform a longitudinal enterotomy. And the middle point would be the area where we do the sliding in an isoperistaltic configuration. The back wall is closed in 2 layers. Most of the time, it suggests the first layer is a running layer and the second as an interrupting layer, as a reinforced suture. And the front wall in the same shape. There are sometimes not recommended, for example, colonic stricture, for example, when there is perforation of fistulae, or for example, when the hypoalbuminemia is below 2.0. But the biggest indication is a patient that had already one or more than one procedure, because we want to avoid small bowel syndrome. And this is our clinical case. We are talking about a lady. She was born in November 2010 with a father history of Crohn's disease, with a thalassemia tract. She was referred to our gastroenterology team in 2016 when she was 5 years of age. They found a Crohn's disease localized in the hyalocolic region with an alastenosis. And then they start treatment. They start treatment with methotrexate and then adalimumab as a first line. But after a couple of months, she had loss of response. Then they tried with infliximab and then thalidomide with no big response. And this is the timeline of the surgical history of this lady. In December 2018, she went in our theater for a laparoscopic resection, was 15 centimeters. And for 5 years, she was well. In 2011, the entero MRI showed active disease. And then the gastroenterology team started promptly adalimumab. In June 2021, she developed no response to adalimumab, and then she was enrolled in the treatment with ustekinumab, that is an interleukin-1 similar like. In January 22, the new entero MRI showed no sign of recurrence, and she carried on with this treatment. But unfortunately, in November 22, the new control showed an active disease in a jejunal loop. In December 22, she underwent an endoscopy, and the gastroenterology team found duodenal ulcer. So they start an aggressive treatment with vedolizumab in combination with this new medication, ustekinumab. She developed constant abdominal pain. And then at the end in March 2024, the MRI show again jejunal stenosis. And these are the depiction of our entero MRI, where you can see here the long area of the jejunal loop with the stenosis and with the thick mesenteric wall. And therefore, after a multidisciplinary team, we decide to go for surgery again. In this clinical setting, we use this technology that we heard this morning, ICG, that with the Rubina lens. And we use this camera that is for open procedure, is the Rubina lens, ICG, endoscope 90 degrees. And these are the video of our procedure. We identified the loop of bowel. You can see the thick wall, thick mesentery, and then we manipulate the bowel to see stricture Importantly, we measured the length of the bowel, and this loop was 55 centimeter length. And this is important because we heard this morning, we need to keep documentation of this length of bowel. We identified the middle area, we inject the ICG, and you can see from this high definition picture, the area where there is no blood supply, that will be our area of resection with the thicker stenosis, and therefore we can precisely do the resection. We can also use the monochromatic technology, and even with the monochromatic, you can even deeply see better the vascular supply. Therefore, we do the resection of this short segment bowel with the thick stenosis. And even here, you can appreciate the quality of the bowel. The resection go on, and then we will get ready to perform the Michelassi stricturoplasty, the isoperistaltic stricturoplasty. After the resection, we ask the nurse, of course, every time to keep all the measurement. We take these 2 loops of bowel and we start to do the first wall. We usually put some stitches to keep this loop in place. We start with our interrupted suture. It's a very long suture, as you can see. And then we need to keep every time in mind to approximate well the bottom layer, because we don't want redundant piece of bowel within the loop. We need to be in a very well shape. We open the bowel, and then we create, of course, these 2 open loops. As you can see from the picture, this is like 20 centimeters of stricturoplasty. The second loop, of course, you can also see the quality of the bowel with this ulcer inside is very bleeding. And then we do our second wall. You can do as an interrupted stitch, or we can do as another long running suture. In this case, we decide to do a running suture again. And as you can see, we use a Prolene, a PDS stitch. We do the angle. Again, in running suture. And this will be a critical point of the Michelassi because of the angle. We need to keep in mind that we have completely 2 open loops. Sometimes they advise to do a V-shaped cut of this bowel. In this case, we didn't do that. We do that again, the second angle. And then we carry on, of course, with another very long running suture. This is a keep consuming procedure, but of course, as you can see, we did preserve a lot of bowel. Instead to do 55 centimeters of resection. This camera that we are using is the Rubina lens, is not the video, it's the same camera we use for the Rubina lens. And you can see the incredible quality of the 4K. Then we do again the ICG because we want to make sure of the blood supply of this very long stricturoplasty. As you can see, the green over the picture is brilliant because you can deeply see in real time the blood supply and the vascular supply. But then we will move shortly to the monochromatic because we want to see perfectly the line of the suture. And as you can see, the green is also going where is the mesentery, where are the lymphatic vessels, because in the cyanic green is able also to see the lymphatic vessels. See, in the one of the loop looks more green, the proximal one, because the disease were very strong in that area. We are moving again to the monochromatic picture. You can see the healthy bowel and then this our structuroplasty, very well perfused, with no picture or image of necrosis. This is a key component because of this long suture. There's another technology that this machine can give you is the intensity map. And you can see where the area is more perfused. You can also use this one to check the lymph node in the mesentery, as you can see here. And this is just a brief snapshot of this technology. If we can use the overlap of the monochromatic, it's very important because we can do the resection in a precise shape. But most importantly, when we perform the long anastomosis, ICG gives to the surgeon a very, very nice idea if the procedure is performed in a good way. The lady stayed with us for 12 days. She stopped the biological treatment. Now she's fully fed. She can open her bowel with no problem. And at the moment, she got no complication. The next follow-up will be at the end of the month. So in conclusion, this new technology provides precise visualization. We can use this technology not only for laparoscopic procedure, but also for open surgery. And this integration will enhance surgical precision technique. And this will improve also long-term follow-up patient outcome. And in conclusion, we need to carry on creating new technology for do personalized surgery in this patient and carry on treating the Crohn's disease patient the best way. Thank you for the attention.
Thank you very much, Dr. Coletta, and thank you very much, Antonino Morabito, that is the chief. Thank you. There is question from the audience or comment from the discussant.
May I say something?
Giovanni.
First of all, congratulations, Riccardo, and also Antonino for this case and this experience, which is very illuminating. I have a question about the outcome. So I have done, in some cases, also even 6 structuroplasty, and the patient didn't underwent to other surgical procedure later during some years. But the question is always about the outcome. Are you sure that there was no active disease? I mean, because and did you continue in this patient the biological therapy after the structuroplasty?
Thank you, Professor Ricci-Peditoni, for this very interesting question. So about the outcome, the adult surgeons got the vast majority of the outcome, and the Michelazzi procedure interestingly showed that even if you perform the structuroplasty in an active piece of bowel with a disease, later on this piece of bowel is getting healthy and the disease can develop in a different part of the bowel. In this patient, of course, she's a very young lady. The procedure is a recent procedure. The next follow-up would be at the end of the month. But at the moment, our GI team decided to stop all the biological treatment. So of course, a close monitoring is important. Of course, enter-MRI will be performed at least every 6 months of time. And then, of course, we are going to do a GI, an endoscopic check. This is very important because there is no huge experience with this kind of structuroplasty in pediatric population. We only perform 2 at the moment. The first one is okay. It was a teenager as well, boy this time. And this is the second one. But as I said, we decided this technique because the segment was very long, was 57 centimeters.
Thank you. I think it was a good solution, especially in a short bowel patient as she was.
Massimo, you have comments? No. It's very interesting, the use of the Rubina, and I think there is indication also for the whole pathology of intestinal when we we have a problem to check the vascularization. And I think it's very interesting also in the treatment of the atresia. When we do the tapering of the intestinum, and it's important to know very well what is the vascularization and what is the blood supply. What do you think, Antonino, about this? You have experience in the use of neonatal or atresia or other tapering for intestinal pathology?
Thank you, Mario. No, we haven't used this technique for athresias. Of course, bowel preservation is paramount in this kind of condition. I believe we need to explore this avenue, and I think it's something that we need to look into in details. Thank you.
Okay, thank you. Luigi Dall'Olio. I see Luigi Dall'Olio is returned from the theater. You have experience, Luigi, for this instrument, the Rubina?
No, we don't have experience about this instrument, but I would like to discuss about the cycturoplasty.
Yes.
Because we published many years ago, I think more than 10 years ago, our experience, and we had very interesting results about this strategy. But then the problem was that the gastroenterologists asked us not to leave in place the inflammatory tract of bowel, but to remove it to have better results by biologic therapy. So we changed our strategy to the resetting surgery, even if we prefer to perform cycturoplasty in case of multiple strictures in the small bowel. I remember when we performed a modified Michelasi technique. We treated together also with other adult colleagues like Francesco Tonelli and Poggioli, because we used this modified Michelasi because we overlap not two tracts of stenotic bowel, but the dilated tract of the bowel proximal to the stricture. And we treated, I remember one case of 60 centimeters strictures in the jejunum with very, very good results. So I think that we have to discuss it and to evaluate together with the gastroenterologists the importance of this strategy, because the opportunity to save intestinal length in patients that probably will have more surgery, it's important. I don't have an answer about it, but in the last guideline of the European Society, the gastroenterologists suggested also to remove inflammatory tract of bowel, with not a good response to the biologic treatment, even if not stenotic. So it's really a challenging problem. But I think that it's important that the surgeon have to be able to perform different strategies and have experience in all the different techniques that is possible to use in Crohn's disease. Thank you.
Thank you very much, Luigi, for your comment. Thank you, Riccardo Coletta and Antonino Morabito. Now I ask if Dr. Vincenzi is ready for the presentation.
So good morning.
Okay.
Good afternoon to everyone. And even in this case, it's a pleasure for me to introduce Francesca Vincenti. She is very fond in nutritional aspect in inflammatory bowel disease. So Francesca, please start your presentation. Thank you, Mario, again.
Good morning. Thanks a lot for your invitation. My English is so better than not so good, and I prefer to speak in Italian. Sorry, my presentation is in English. About then medical and nutrition treatment when surgery will indicated. Possiamo spostare un po' questa? Noi sappiamo quindi che il rischio di intervento chirurgico nel paziente affetto da...
Trovate la mia borraccia. La conservate. Nessuno ruba niente là.
Non so. Can I speak? Sorry? Forse non sentono.
Che cos'è?
Non so.
Okay.
No, you can go.
Ok, sorry.
Yes.
Noi sappiamo che il rischio di intervento chirurgico nel paziente affetto da malattia infiammatoria cronica si è modificato nel tempo da, come compare in questa corte danese, dal 50% al 20% in epoca più recente a seguito dell'introduzione delle terapie biologiche. Questi stessi dati sono confermati da una corte svedese, rimane tuttavia il rischio appunto di complicanze post-chirurgiche. Rimane tuttavia il rischio di complicanze chirurgiche, come riportato anche in quest'altro studio, dove tuttavia non appare così evidente la riduzione del rischio di intervento chirurgico, soprattutto nel morbo di Crohn. E gli stessi dati li ritroviamo anche in età pediatrica, dove effettivamente il paziente, nonostante l'introduzione appunto di una terapia biologica, incorre in intervento chirurgico nel 13% dei casi a 5 anni della diagnosi e in oltre il 25% a 10 anni dalla diagnosi. In questo studio si evidenzia anche come diciamo, a seguito dell'introduzione della terapia biologica il rischio di intervento chirurgico è pressoché sovrapponibile anche a seguito dell'introduzione delle terapie biologiche. Che cos'è quindi che rende l'atto chirurgico diciamo che può complicare appunto l'atto chirurgico? In questa paper del 2009 vengono presi in causa i fattori che sono fattori legati al paziente o fattori legati all'operatore. E i fattori legati al paziente comprendono la malnutrizione, l'utilizzo di steroidi, il tabacco e l'alcol. Quindi che cosa possiamo fare rispetto appunto alla chirurgia per preparare il paziente e per ridurre quindi il rischio di una complicanza chirurgica? L'atto chirurgico è un atto che comporta una condizione di stress che coinvolge appunto il sistema nervoso centrale, che coinvolge il muscolo, che coinvolge tutto il metabolismo glucidico. E quindi già agli inizi del 2000, e sono ahimè passati 20 anni, si parlava di un protocollo ERAS che come sappiamo è in teoria ampiamente utilizzato appunto nell'adulto, mentre in età pediatrica non se ne parla, ma sottolinea l'importanza della preparazione del paziente all'intervento chirurgico, e nel protocollo ERAS ha la funzione diciamo di attenuare questa risposta allo stress chirurgico del paziente sottoposto ad intervento. Il protocollo ERAS prevede appunto una diciamo degli atti in fase immediatamente preoperatoria, intraoperatoria e postoperatoria, e coinvolge la figura dell'anestesista, coinvolge appunto chi è chiamato a prendere in carico il paziente dal punto di vista nutrizionale, l'atto chirurgico, e al fine di mobilizzare rapidamente appunto il paziente. Una azione, diciamo, che è complementare rispetto al protocollo, un'azione che è complementare rispetto appunto al protocollo ERAS è la preabilitazione, che ha la funzione di preparare il paziente all'atto chirurgico, migliorando quelle che sono le riserve, le capacità di riserva del paziente. Ci sono degli studi che sono soprattutto sorti, diciamo, nell'ambito della chirurgia addominale, soprattutto del paziente oncologico, dove questo è datato del 2019, dove si sottolinea appunto l'importanza e l'efficacia di una presa in carico del paziente con preabilitazione. Uno studio più recente di fine 2023, dove appare evidente sempre nel paziente adulto sottoposto a resezione colica per neoplasia del colon retto, dove si evidenzia appunto che il paziente sottoposto a preabilitazione ha una significativa riduzione appunto di complicanze rispetto al paziente appunto che non viene diciamo seguito secondo la preabilitazione. Questa umbrella review sottolinea ancora ulteriormente l'importanza della preabilitazione, dove sono state sommate, diciamo, delle review che coinvolgono appunto pazienti sottoposti a chirurgia addominale di varia natura, che può essere appunto ginecologica, che può essere una chirurgia addominale non oncologica, che può essere appunto la chirurgia oncologica o delle malattie infiammatorie croniche, dove emerge che effettivamente si ha una riduzione delle complicanze, una riduzione della mortalità, del dolore, della durata del ricovero e non ultimo appunto una riduzione appunto dei costi. Sicuramente rimane, ne stiamo parlando, è un protocollo complesso e sicuramente dobbiamo identificare come ottimizzare l'approccio appunto secondo una preabilitazione in termini di selezione del paziente, del disegno proprio dell'intervento da attuare, l'aderenza alla strategia, perché si parla di preparare il paziente 4 o 6 settimane prima dell'intervento chirurgico, e quindi anche la durata stessa dell'intervento. Interessante secondo me è diciamo, questo grafico del 2022 della British Journal of Anesthesia, dove si vede chiaramente che il paziente che è diciamo che arriva all'atto chirurgico con elevate riserve energetiche e con una riduzione dello stress chirurgico secondo quindi il protocollo ERAS, avrà un'evoluzione post-chirurgica eccellente, una ripresa eccellente. I pazienti invece che arriva con un elevato stress chirurgico e che non arriva preparato, quindi con una bassa capacità di riserva, è un paziente che avrà un post-chirurgico, una ripresa sicuramente peggiore. Le componenti della preabilitazione sono l'aspetto nutrizionale, l'attività fisica e l'aspetto psico-emotivo. Per cui generalmente per quanto riguarda l'aspetto nutrizionale è volto a cercare una condizione di malnutrizione che normalmente viene definita secondo appunto i criteri GLIM, ovvero una perdita di peso, la presenza di sarcopenia e il BMI e un fattore eziologico come nel caso appunto delle malattie infiammatorie croniche, e per cui la malnutrizione ha una sua definizione precisa in termini anche di gravità, ma il paziente, come ben sappiamo, può essere anche un paziente sarcopenico in cui apparentemente il BMI è conservato ma ha una riduzione della massa grassa, della massa magra. Nello screening nutrizionale ovviamente ha un significato cercare se c'è uno stato di infiammazione, se c'è una condizione di cattivo controllo glicemico, se c'è un'anemia, e mettere in atto quindi delle misure terapeutiche. Questo lavoro del nel 2022, che è volto principalmente proprio a pazienti affetti da malattia infiammatoria cronica, in particolare pazienti sottoposti a restrizioni per morbo di Crohn. Si trova lo screening, come ci siamo detti, e un intervento nutrizionale che ci dice proprio che l'intervento nutrizionale può essere preso in considerazione nel preoperatorio quando le condizioni nutrizionali non sono adeguate e quando è anche inadeguato l'apporto calorico e proteico, e prevede una durata di 1-2 settimane o addirittura può essere esteso a 6-8 settimane. E ancora ci dice che una nutrizione interale esclusiva potrebbe essere considerata come un supporto per l'immunomodulazione, per l'effetto immunomodulatorio e la riduzione quindi soprattutto delle complicanze post-operatorie. La stessa ECO ha in questa topical review, dove sono stati presi in considerazione più aspetti del paziente che deve essere candidato a chirurgia per malattia infiammatoria cronica, ci dice che una nutrizione interale esclusiva in preoperatorio nel paziente con malattia complicata, d'altra parte è il paziente che va a chirurgia, migliora le condizioni nutrizionali del paziente e probabilmente riduce il rischio delle complicanze appunto post-operatorie. La stessa ESPEN, che è la Società Europea di Nutrizione, sottolinea l'importanza dell'applicazione del protocollo ERAS, che nasce principalmente appunto per la chirurgia oncologica, e sottolinea anche l'importanza di differire l'intervento chirurgico di 1-2 settimane se questo consente di migliorare le condizioni cliniche del paziente. Questa raccomandazione è talmente forte che anche per il paziente oncologico che deve essere candidato a chirurgia, ci è consentito di ritardare appunto l'atto chirurgico anche di 2 settimane se questo consente di migliorare le condizioni del paziente. Quindi che cosa possiamo fare dal punto di vista nutrizionale per condurre meglio il paziente all'atto chirurgico? Questo documento recentissimo dell'American Gastroenterology Association ci dice come, a seconda della condizione clinica in cui si trova il paziente, che cosa diciamo attualmente possiamo proporre. E in particolare quindi ci propone che in caso di una malattia attiva, colica, o del paziente malnutrito che va ad atto chirurgico, sottolinea l'importanza appunto di una nutrizione interale esclusiva con prodotti liquidi di formula. Tutti noi che penso ci occupiamo di malattie infiammatorie croniche ne conosciamo uno in particolare che è arricchito del TGF-beta. In realtà la letteratura attualmente non pone delle indicazioni molto selettive, ma è sufficiente l'utilizzo di un prodotto diciamo polimerico, e sappiamo quindi che una nutrizione interale esclusiva è capace di indurre una remissione clinica ed endoscopica del paziente affetto da Crohn, e sappiamo bene che questa evidenza è più forte in età pediatrica rispetto all'adulto. Lo scopo, gli obiettivi diciamo di questa approccio nutrizionale è proprio quello appunto di migliorare le condizioni nutrizionali del paziente, di indurre mucosal healing, probabilmente di cambiare il microbioma e il pathways delle citochine, e quindi tutto questo comporta un outcome migliore dal punto di vista chirurgico. Gli studi ci sono in letteratura che dimostrano come una nutrizione interale esclusiva è efficace appunto nell'indurre una rapida remissione e la non necessità di una terapia steroidea, senza che sia incrementato appunto l'uso della terapia biologica e la chirurgia nei pazienti trattati appunto con una nutrizione interale esclusiva. Ci sono studi che dimostrano anche l'efficacia appunto della nutrizione interale anche in pazienti malnutriti, per cui assolutamente l'outcome diventa sovrapponibile in termini di complicanze post-chirurgiche al paziente che è ben nutrito, che si presenta all'atto chirurgico nutrito, e i dati sono sempre più anche a favore di un cambiamento di quello che è il microbiota, che poi a distanza di tempo torna ad essere quello iniziale, ma probabilmente nell'immediato post-operatorio questo cambiamento è a favore appunto della remissione, probabilmente per una mutazione della permeabilità della mucosa intestinale. Sappiamo tutti però che una nutrizione interale esclusiva ha una ridotta, diciamo, compliance da parte del paziente, sia esso paziente adulto o pediatrico. Talvolta noi che abbiamo anche l'esperienza nell'età pediatrica sono quasi più complianti i bambini che l'adulto. Generalmente sono complianti nella fase di acuzie della malattia, cioè durante il ricovero, nel momento in cui il paziente inizia a migliorare le sue condizioni, diventa più difficile proporre la prosecuzione appunto di una nutrizione interale esclusiva. È per questo quindi che si è affermato in questi ultimi anni anche questa dieta SEDED, cioè una dieta di esclusione che è costituita appunto di una nutrizione interale parziale, affiancata diciamo con l'introduzione di alcuni elementi, come di nuovo viene rappresentato in questa diapositiva del lavoro più recente. Questa dieta sostanzialmente quindi presuppone 3 fasi: una prima fase costituita di un 50% di una nutrizione interale esclusiva, come dicevamo, di un prodotto polimerico, e una dieta invece con cibo diciamo esclude tutto ciò che caratterizza, ahimè, attualmente la dieta occidentale, quindi zuccheri semplici, quindi carni rosse processate, quindi additivi e emulsionanti, a favore invece appunto di una dieta con fibre, di una dieta che genera appunto di substrati che generano degli acidi grassi a corta catena, migliorando anche la qualità dell'apporto delle proteine che vengono apportate, allo scopo sempre probabilmente di migliorare, di ridurre la permeabilità intestinale attraverso appunto un cambiamento nel microbioma. Questi sono gli studi che dimostrano appunto l'efficacia della dieta SEDED rispetto appunto a una dieta normale, e come primary endpoint di questo lavoro si vede come la dieta SEDED, quindi con una parziale nutrizione interale esclusiva, quindi con un miglioramento della compliance del paziente, è meglio tollerata che una nutrizione interale esclusiva. Oltre che entrambi gli approcci SEDED con nutrizione parenterale parziale e nutrizione interale esclusiva sono entrambi efficaci nel raggiungere la remissione a 6 settimane. La SEDED sembra addirittura essere superiore nel mantenere la remissione a 12 settimane. E di nuovo si sottolinea in questo lavoro l'importanza quindi della riduzione della permeabilità intestinale, riducendo in questo caso appunto la presenza di proteobacteria. Quindi i dati sono a favore di una nutrizione enterale in prossimità dell'atto chirurgico, che diventa quindi una parte integrante della preabilitazione appunto del paziente, proprio non solo in termini di miglioramento delle condizioni cliniche del paziente, ma anche diciamo come probabilmente miglioramento anche della permeabilità intestinale. Un piccolo appunto anche in merito alla terapia, che è un tema altamente dibattuto, di come portiamo il paziente appunto all'atto chirurgico. Sono pazienti complessi che hanno fatto spesso più trattamenti biologici, e quindi qual è il momento opportuno per sospendere appunto la terapia. Sempre secondo questa review della ECO possiamo proseguire le terapie biologiche fino al perioperatorio, poi rimane da stabilire effettivamente la tempistica, ovviamente, ma penso che sia esperienza di tutti, è opportuna la sospensione o la riduzione al minimo. Nella nostra esperienza assolutamente usiamo ormai pochissimo gli steroidi, e sicuramente non portiamo il paziente all'atto chirurgico con lo steroide. E ritornando quindi al lavoro che ho mostrato prima, effettivamente ci viene sottolineata ancora l'importanza della riduzione fino a sospensione dello steroide, e considerano come i dati per esempio di ustekinumab e di vedolizumab sono pochi anche nel lavoro della ECO, ma ci propongono come tempo per l'adalimumab 4 settimane prima rispetto all'intervento chirurgico e 6-8 settimane prima per quanto riguarda l'infliximab, anche se i dati sono un po' discordanti, nel senso che il fatto di proseguire una terapia biologica abbassa, diciamo, lo stato flogistico con cui si porta il paziente all'atto chirurgico e d'altro canto può prevalere invece l'effetto immunosoppressivo che ovviamente conosciamo. Questo è il caso di una giovane donna che è arrivata a noi dopo in epoca Covid nel 2021 con una diagnosi fatta presso un altro nosocomio e ci viene inviata per la presa in carico. La paziente arriva ad una visita ambulatoriale con però un quadro con esami ematochimici significativi, con una iposodiemia, con una PCR che è almeno 10 volte il normale, per cui siamo costretti a ricoverare appunto la paziente al primo incontro. È il momento in cui facciamo tamponi a tutti, per cui la paziente fa il tampone e risulta essere anche positiva al Covid. A quel punto, stabilizzato un attimo il quadro diciamo clinico internistico generale, inizia una terapia con corticosteroidi che insomma non iniziamo mai come primo approccio, ma in questo caso siamo costretti per il quadro della malattia ileocolica e per la concomitante infezione da Covid. Dopo appunto 6-8 mesi facciamo il controllo appunto della coloscopia, sostanzialmente dopo la terapia con il corticosteroide, e ritroviamo nuovamente una malattia che colpisce in modo importante appunto la valvola ileocecale. La paziente per un certo periodo appunto rimane ben sotto controllo appunto con la terapia con infliximab a 5 mg pro chilo. Questa immagine che ho presentato però evidenzia comunque un'attività di malattia, per cui decidiamo di aumentare a 10 mg il dosaggio dell'infliximab con un controllo non ottimale. La paziente sta bene, ma la calprotectina comunque è aumentata rispetto ai valori di normalità, la PCR è sempre lievemente aumentata, fin tanto che nel corso del 2023, pur mantenendo sempre delle condizioni di stabilità clinica, si ha un'impennata proprio degli indici di flogosi, per cui si controlla anche con una TAC per eventuali complicanze fistolizzanti, che in realtà è negativa. Si fa un consulto anche reumatologico perché talvolta anche dei dolori articolari, ma sembra essere questo negativo. Pertanto si decide di associare anche una seconda terapia biologica con l'ustekinumab. In realtà al controllo a circa 6 mesi appunto dall'inizio della terapia troviamo questo quadro molto importante, sempre a carico della valvola ileocecale, per cui a questo punto la paziente in assenza di altre localizzazioni e nella quale abbiamo ottimizzato una terapia con anti-TNF-alfa, abbiamo associato anche ustekinumab, decidiamo di portarla appunto all'atto chirurgico. E allora in questo caso l'utilizzo appunto di una dieta SEDED ci ha consentito di portare la paziente all'atto chirurgico preservando delle buone condizioni nutrizionali, con un'albumina nei valori di normalità, una prealbumina normale, un BMI nella norma e conservata pure la composizione corporea rilevata appunto con la VIA, e quindi intraprende appunto questo schema dietetico. Ho dimenticato di dire che la paziente è originaria del Bangladesh, per cui aderisce facilmente alla dieta, che è senza glutine, per cui diciamo i carboidrati complessi sono rappresentati principalmente dal riso e ovviamente le sue farine del riso, e quindi in queste condizioni la paziente arriva all'atto chirurgico con appunto una PCR che si è francamente ridotta, per cui ha subito una resezione ileocecale in un unico tempo, l'anastomosi con una rapidissima dimissione, e la paziente si è ripresa rapidamente dopo l'atto chirurgico. Ha un significato in tutta questa, diciamo, presa in carico del paziente anche il valore dell'albumina, che sappiamo può essere deficitaria sia per le condizioni di malnutrizione ma anche per lo stato flogistico, e in questo caso la paziente è arrivata all'atto chirurgico con valori assolutamente conservati. E quindi per concludere, prima della chirurgia quindi è importante, diciamo, la preparazione del paziente all'atto chirurgico? Beh, direi assolutamente di sì, con la preabilitazione e l'ERAS. Possiamo fare qualcosa dal punto di vista nutrizionale? Sembrerebbe di sì, e rispetto appunto ai trattamenti sicuramente sono da sospendere e possibilmente imbricati appunto con una nutrizione enterale, se possibile, che effettivamente ha un'efficacia sulla evoluzione della malattia. Grazie, scusate ancora per la presentazione in italiano.
Thank you very much for your nice presentation. And there is a question from Professor Gianchetti. Please, Paolo.
I would like to know, why did you choose to add ustekinumab to the infliction for a terminal ileitis with substenotic lumen? What did you want to do? Which one could be the conclusion? That it was better, it was a failure to infliction with the stenosis, so the patient should underwent. There is no evidence in literature to put together ustekinumab with infliction. In my opinion, you worsened the situation, determining a more stricture, a more important stricture on the patient. So probably it was better to underwent the patient, put the patient in the surgeon to the surgeon, resolve the situation before, and then in case of recurrence, early recurrence, start again the biologic. There is no evidence for adding in this case. In every case, so there are only open studies and no studies confirming the disease. But particularly using infliction and ustekinumab, there is no evidence. Second, it was perfectly unuseful to use that. I don't think so. This is the right way. The patient wasn't, because the stricture was more important, and therefore you did the only things to be done in one terminal ileitis with stricture, so the surgery.
Well, thanks for your consideration, but there was only inflammation in the end of ileum, and with substenosis, not strictures in ileum cecum, and then we try to treat with the second biological therapy.
The patient was a failure to infliction, you should stop infliction and try another therapy. There is no evidence to put together infliction and ustekinumab in a case like this.
We try only
to anti-TNF, you have to stop anti-TNF. Also because you expose the patient to many possible complications. In fact,
we try only about 6 months, and then we try to do it.
Thank you very much, Dr. Vincenzi. There is other question or a consideration from our discussant or Luigi?
I want just to emphasize what Professor Gianchetti said, and I want to say that with the new technique, especially laparoscopic and robotic techniques, we can feed these patients very early, after 48 hours. So the importance of nutrition, which is really very important and became a key point today, can be respected also post-operatively. This I want to underline as a new consideration.
Thanks.
Luigi, you have a comment about this discussion? Luigi Dall'Olio? Don't hear me? Okay, thank you very much, Teresa Vincenzi. Thank you. And now I call Valerio Gentilino, because if it's possible, we do immediately the second question time. Valerio?
Yes, Prof, I'm just giving the floor to Ilaria Manghi. second-year pediatric surgery resident in Bologna, who will
Yes.
be presenting another weird and confusing case from her institution. So please, Ilaria, be so kind to share your screen and your clinical case. Thank you.
Okay. Can you hear me?
Yes, we do.
Yes, it's good.
Okay. Good afternoon, everybody, and thanks to Dr. Gentilino for the presentation. This is a wild case, clinical case we faced some week ago. Nothing was clear at the beginning because of the atypical presentation of the patient. He's a 13-year-old boy referred to our pediatric emergency room, complying a new onset fever and epigastric pain with back and bilateral flank irradiation. The patient described worsening and continuous pain. Blood analysis fulfilled in emergency pattern show normal white blood cells with a high percentage of neutrophil and the normal liver and pancreatic function. The PCT was negative and reactive C protein was high in his value. At this point, which radiological examination would you have performed as first line? Abdominal ultrasound, abdominal X-ray, or abdominal CT scan? I ask Professor Lima to send the question. Okay. I think that in this phase of the initial investigation, maybe a first line could be a good examination, and maybe now let's see, what are you thinking about it? Okay, and I see that almost of you agree with our choice. In fact, only one moment. Okay. In fact, we choose to perform as a first line radiological examination with abdominal ultrasound. And this was the imaging. But despite help us to clear our minds, the ultrasound stressed out that in epigastrium there is a marked hyperechogenicity of the mesenteric adipose tissue. The head of the pancreas appears more globular and hyperechogenic, with poorly definable profiles. There is also a marked thickening of the walls of the gastric antrum and the first portion of the duodenum, as you can see maybe in the images. So, what would be your first clinical suspicion? Pancreatitis, duodenitis, inflammatory bowel disease, or cholangitis? I think now it's a little bit difficult to underline the correct and the right cause-effect connection because of these findings, because of the thickening of the wall of gastric walls and the duodenum, but also an enlarged pancreas. So let we see. Okay. It's a little bit difficult, and I suppose that the most of you relating to your answer would ask for another imaging. And in fact, in order to complete the diagnostic workout, we choose to perform a second level diagnostic abdominal as an abdominal CT scan. And this is the imaging. The report referred dimensional increase of the pancreatic head, main pancreatic duct not dilated, no lithiasis formation, circumferential edematous thickening of the walls of the gastric antrum, and the entire duodenal C-loop. The latter also characterized by a significant increase in thickness and contrast enhancement of the mucosal plane, suggestive of associated gastroduodenitis, and this scan show the presence of an enlargement of the pancreas. Of course, at this moment, the patient was hospitalized in pediatric emergency department to start the therapy with PPI, antibiotics, analgesics, and fasting and fluid, intravenous fluid. Now, with the CT scan report, has your diagnostic hypothesis remained the same or has changed? So which is now your diagnostic hypothesis? Pancreatitis, duodenitis, inflammatory bowel disease, or cholangitis? I guess that the first diagnostic hypothesis, according to the therapy planned by pediatric colleagues, was an acute pancreatitis related to gastroduodenitis, but now let's see what do you think about it. Okay, first, the most of you think that it is an inflammatory bowel disease, someone else a duodenitis, but I think that we can all exclude the cholangitis. So, let's go on with the case. For persistent abdominal pain and blood test showing a normal pancreatic function, the pediatrician's colleagues asked for an upper gastrointestinal endoscopy that found this. So multiple punctiform ulcerative areas in gastric mucosa and hyperemic and inflammatory aspects of the duodenum, as you can see in the second imaging. Finally, based on the clinical, radiological, and endoscopical findings, gastroenterologists start therapy with Moduland and corticosteroid because of the high suspicion of Crohn's disease. There was a rapid clinical improvement with the symptom remissions and the normalization of PCR levels. Even so, the endoscopical findings were suggestive for inflammatory bowel disease. Only the histological examination can ensure the diagnosis, and this was the case. So the patient was discharged with Moduland and corticosteroid therapy in décalage. And in this patient, for this patient is plan in the next future the starts of the biological therapy. Thank you so much.
Thank you, Ilaria. Very well presented case. The paper is open for discussion. Any question from the floor or from the discussants? What do you think is the take-home message, Ilaria, from this clinical case?
I think that the take-home message could be that nothing is clear from the beginning, and it's better to make a diagnostic evaluation, more than one diagnostic evaluation, because of I think that in this case the first cause of abdominal pain could be pancreatitis, but we can see that in reality it was an inflammatory bowel disease, and we need an endoscopical imaging to find it. So nothing is
Ma
simple.
parti tu con una delle tue, perché hanno bisogno ancora di un quarto d'ora in sala, va bene? Bene.
Il microfono aperto.
Sì, scusate, excuse me, and if there is no question from the audience, I ask to Giovanna Ricipetitoni, because the operative theater is ready 10 minutes a quarter. And if you want to start, Giovanna, with your presentation to SEAL's approach in IBD surgery. Yes. Thank you.
Minute, Mario. I try to share my screen. Okay. And we are. I hope you can see me.
Yes, we see.
I try to put in full screen presentation. Where it is down. Okay. Full screen. Okay. Okay. That down. Avviso di sicurezza. Okay. Okay, I think you can see my screen. So my experience is obviously a limited experience that I developed mainly when I was in Milan. I have treated some cases also in Pavia. And during my mini-invasive experience, I developed experience in single-site mini-invasive surgery. So looking to the literature, there are a lot of reports about the use of single port for colonic surgery, for tumor, and also for IBD. So I try to use this approach in IBD patients. I try to go on. As you know, we may have a different type of single site device. You can have homemade port and the preformed port. There are different types. I prefer to use the SEALS port because it's a sponge. It's very delicate, also for children, and it can give different trocars, 3 5 millimeters trocar, or 112 and 2 5 millimeter. Generally, it is not easy to use this device, but if you have some experience, it can be also feasible due to some tricks. First trick, if you have a longer optic, to put the optic at the top or down in the ergonomics of the sweet trocar in order to have less disturbance from the operative port. Obviously, there are other kind of ports more similar to the Alexis that also adults use for small laparotomy. And the smallest one is the mini gel port that use a small mini Alexis with a sort of device with 3 different trocars. Look into the literature. If you look back, the first SEALS hysterotomy was described in 2092. Then ciscolonic surgery was discussed in 2008, and there is also some important article as this one, single incision laparoscopic colonic and rectal surgery for pediatric inflammatory bowel disease and polyposis syndrome. Coming back to the questions that I advanced today to the Bologna group, who are really a unique experience, obviously, I think that this device can be more advisable for pediatric and adolescent patients rather than for adults, because a SEALS device is too small for an adult to eviscerate all the bowel. But for the children, up to 10 years, it can be really okay. And if you look to the literature also, the rate of complication using laparoscopic surgery and seals is not really significantly different. On the other hand, sometimes the results are mainly also better. But I want to say, look into this very nice article, single incision laparoscopic surgery for children with Crohn's disease, published on Pediatric Surgery International. It seems that there is no difference between seals and open surgery. And I think this is true. If the incision is a small incision, about 2 centimeters, in the past, they proposed a flexible instrument. I have to say that we used some of them, but now they are very expensive and we learn to use the conventional instruments. And I want to say that is the ultimate changer of the conventional video-assisted therapy in colonic surgery. Our experience is a limited experience. I performed a 25 seals procedure in 19 patients. Why the difference? Because some patients had an ileostomy, and then we use the site of the ileostomy to put the seals to construct the ileal pouch. They were 12 Crohn's disease and 7 ulcerative colitis with an age ranging from 7 to 18 years. I have to say 7 was just one girl with a fulminant ulcerative colitis. The other one were mainly adolescent patients. Some cases, this is a case of ileocecal stenosis in Crohn's disease with a sort of mass. And so this patient needs to be treated. And we used to mobilize the colon inside the abdomen as the group of Professor Poggioli, Professor Rottoli showed very well today. And then we extract the bowel through the umbilical access. And if you look to the patient, is not so fatty, and the access of the seals is enough to take out the bowel, the ileum, and also the colon to perform an anastomosis. At the beginning of my experience, we started more than 10 years ago, we used to do a hand anastomosis. Then we changed it, and I will show you. We use a stapler anastomosis, a functional terminal anastomosis, exactly the same that Professor Rottoli demonstrated today, because I have to say I collaborate with the adult surgeon, expert in IBD in Milan, and we established the protocol of treatment, and they went to help us at the beginning. So the results I have to say, were after very satisfactory. Just a few images. I hope, no, my video is not working, doesn't matter. So this was the end anastomosis, look at the end, and this is working. The G anastomosis, exactly the same that Professor Rottoli showed today. If you look to the bowel, a lateral, then we cut longitudinally the lateral part in order to have a functional wide terminal anastomosis. So, and I have to say that this kind of anastomosis till now has not given a stenosis at a longer term follow-up of that patient that I have treated. As another case is not so different. I look to the terrible stenosis. Oh, now the video is working, but the principle is exactly the same. This was an endoscopic view of the stenosis, and we use the appendix to traction the bowel. If you look to the ileum mesentery is very damaged as the adult case of today is very typical. And then when the mobilization of the ileocecal corner and sometimes of the ascending colon is completed, the bowel is extracted through the seals. The advantage, so in some cases, recently we used the robotic stapler instead that the common GIA is much more expensive, but this is just to demonstrate that you can do also if you are very expert. I am not, but if you are a big expert, you can do the anastomosis completely in. And some French colleagues used to do this surgery completely in. And I think that with robotic Signa is easier to do this and is more safe. I don't want to spend more time, but just to go back to the results. So we treated 12 Crohn's disease, 11 ileocecal stenosis, and 1 ileocecal stenosis plus 6 ileal stenosis where we performed a stichtudoplasty. And this was really strange for me, but I have to say that more than 10 years later, this girl has no more recurrence, maybe due to the good treatment that the gastroenterology has performed. So we had no intraoperative complication regarding the type of anastomosis. The first 5 were made by hand. The last 7 were stapled, and I think we have to do stapled, because if you look back to the literature, especially to what is recommended by Combe, who is a big expert in IBD, there is a demonstration that stapler anastomosis is much better than ensuing. Okay, so if you look, if this is an error, these are ulcerative colitis. I corrected this slide, but unfortunately, the correction didn't come. So this is my experience in ulcerative colitis. I apologize for this. And I treated 7 patients. All patients were patients in untrattable bleeding with acute ulcerative colitis. They followed the echo and Espegan treatment. So they went first to corticoid therapy, then to anti-TFN without any results. So in a short period of 1 week, they went to surgery. And 3 of them were severe hemorrhagic colitis. 7 were patients in bad condition, resistant to medical therapy. In 5 cases, we were able to perform a 2-stage approach. I think that now the 2-stage is very popular, is becoming very popular. But I think that in children can be easier than in adults, because the mesenterium is less thick, the distance are less, so it's possible to do a colectomy and then ileostomy, and then a second time of IPPI reconstruction with J-pouch without performing an ileostomy. This is a big advantage for the child, because he avoid a 3rd operation and avoid also the complication related to the ileostomy. In 2 cases, I have to say these 2 cases were terrible patients with also sclerosing cholangitis. We were obliged to do a 3-stage approach. These were the guidelines published in 2018 from ECHO and the European Society of Pediatric Gastroenterology, Pathology and Nutrition, and we followed this lean guide for all our patients. What are the advantages of seals surgery? The advantage is that in the first stage, put the seals.
Giovanna,
Yes. See, dimmi.
Is ready from the operative theater.
Okay, okay, we
No,
will stop.
Okay.
We will stop.
Uh,
Doesn't matter.
Professor Rotoli, Michele Libri, you hear me? Michele? Michele,
From outside.
you...
Okay, can you see me as well?
Yes, yes, we see.
All right. So I wanted to start with the external view of the console because I know that not many of you have seen and have tried this platform, especially because it's not yet certified for pediatric surgery. But we use it. It's been certified for colorectal surgery for 1.5 years now, and we have used it for the last year. You know that it's a different concept of robotic surgery as compared to the existing, let's say, gold standard, which is the Da Vinci platform. This is a modular system, so we're going to show you the table, the operative table as well. So but every arm is docked separately. And obviously we have 4 arms. Every arm is the same, so we can switch instruments and the camera from one arm to the other without any problem. Hypothetically, and I have to say also practically, this kind of concept gives you a lot of flexibility. And I think it is particularly important in colorectal surgery because unlike urology or gynecology, we work in a very large field of surgery, right? So let's say that we have to do an anterior resection of the rectum. We have to reach the pelvis, but we also have to mobilize the splenic flexion. So what happens with the existing platform is that it's a bit more difficult to reach that kind of flexibility. While with this one, you can redock even one arm or 2 arms. You can change the position of the arms, and using the existing trocars, you can reach a completely different field. And we have developed our own setups, so we know exactly where the arm should go if we want to reach a certain surgical field. So the console, now we're going to wait for the camera. As you can see, is completely different from the Da Vinci's one because it's an open console. This is a 3D monitor. You're probably going to see the double image, obviously, because you don't have the 3D goggles on. It has the huge advantage of the ergonomics because, as you can see, the surgeon is very comfortable and you can change your own position. And from what I'm told from our urology friends, the Da Vinci position, which forces you to lean forward to get into the binoculars, has been proven to be associated with some back problems in surgeons. While in this one, you can actually find your own position and you are much more free. The other advantage is that you can have 10 people around you and they can see exactly what you see, which is a huge advantage for training as well. So that can't happen with the binoculars and the closed console. You also have a huge awareness of what happens in theater. So whatever happens, if you have conflicts, you can see just looking at the table and you still operate while you look at the monitor. The handles are like this, so they are different from the Da Vinci's one. They are more similar to the laparoscopic instruments, and that's quite good for the surgeons like us who are robotically naive and switch from laparoscopy to robotic surgery. And that is what happens, and is going to happen for 95% of colorectal surgeons all around the world. Most of them are just laparoscopic surgeons. They're very happy with laparoscopy, so we don't need a robot to overcome difficulties of surgery. So we are able to do the procedures, but we can actually get the advantages of robotic surgery. So the 3D vision, the more detailed movements, the accuracy, and so on. So the pedals are quite similar to the Da Vinci one. So we got the pedals to control the energy. There are 2 pedals to control the ligature, so the radio frequency, which is not yet on the market, but it's going to be here very soon, and it's going to change a few things. So it's going to be a game changer, in my opinion. But what I realized using the robot, so as I told you this morning, we always use advanced energy when we do laparoscopic surgery. It's much more practical. It allows you to go also, if you need it, into non-anatomical planes without having serious bleeding. What I realized with robotic surgery is that you can basically carry out the majority of operations without advanced surgery, because the monopolar energy that you can use for the section that we have on the scissors we have that accuracy that you can't have in laparoscopy, obviously, because they don't have the tremors, and you can see the, let's say, the planes, and you can reach exactly what you want when you want it. So if you're happy, we can switch to the intracorporeal view. Is it okay with you? Okay, you told me that it's okay. So this operation is a restorative proctectomy. So she's a young patient with ulcerative colitis who underwent a total colectomy, actually subtotal colectomy, a couple of years ago. We often, so to answer the question that was given to me this morning, most of the times we do a 3-stage operation. I know that there is let's say, quite a lot of push of the scientific community towards the 2-stage or the modified 2-stage approach. But we actually do not agree with many of those findings. I know the surgeons who do it. And if you read let's say, the papers encouraging that kind of approach, the rate of anastomotic leak is much higher than our own, which is about 3%. And the point of doing a 3-stage is that we do the total colectomy when the patient is very sick. You know that those patients usually reach the time of the colectomy when there is nothing else to do, and they are malnourished, and the last step is the colectomy. We give them a few months time to recover, and then we do the reconstructive part. So in this case, we do the total proctectomy, and we'll construct the pouch, and then we'll do a loop ileostomy. I believe that you should always do a loop ileostomy when you do PAD surgery, because even if the anastomotic leak rate is low, if you have pelvic sepsis after the pouch, that pouch is gone. The function of that pouch is so impaired that what happens is that after just a few months or years, you have to do a pouch excision, or you have to attempt to redo pouch, which obviously doesn't have the same outcomes of the primary one. So our approach is always to do a 3-stage. Obviously, there is also the time when we do the 2-stage, so a total proctocolectomy with the pouch and the loop ileostomy. We usually do that when there is a cancer, especially if there is a multifocal cancer, or if we have severe dysplasia in more than one location, and especially in the rectum. So in that case, obviously, we have to take out the colon and the rectum. So what we do here, this is the docking that we use for the vessels. So it's the same docking that we use for when we do the ligation of the inferior mesenteric artery and veins when we do cancer. And as you can see, the camera is on the right side of the patient, and we look at the vessels from the right to the left. My reserve arm, which is this one, it's a Cadier instrument, Cadier forceps. I use it to pull the sigmoid up. We always, unless contraindicated, keep the inferior mesenteric vessels when we do the colectomy. That's because we don't want the rectal stump to get ischemic, and we usually fix the rectal stump to the abdominal wall. It's closed just over the fascia, and that I think is very useful because we see a lot of times that it opens up because the rectal stump is often diseased, and if it opens up inside the abdomen, you can have also quite severe intra-abdominal abscesses, while in this case, you just control a fistula on the skin, so it doesn't give any problem to the patient. All right. So what we do here is we develop the plane, the holy plane. So we go on the same plane that we would follow to do an oncologic procedure. You know that there are a few approaches to this. Some people go with the intramesorectal excision, which has the advantage of keeping your dissection far from the nerves, so that you can have a better outcomes in the postoperative course and in the long term, which makes sense. But what I see is that it's often a very bloody operation. And I don't think it really makes a lot of sense, because now between robotic surgery and the laparoscopy that we have, so the 4K laparoscopy, it's very easy to see the planes and to respect the planes as we should during this operation. So the left arm, sorry, is a bipolar forceps, while the left one is obviously a scissors with the monopolar energy on. So this is the plane that we have to follow. And if I develop this plane, just opening the peritoneum, you see that the image gets even more detailed when I get inside. And I know that these are the nerves, that is the posterior plane. And every one of these nerves can be preserved. That's by doing this. So this is posterior, these are nerves. And what I always insist on is to perform a proper nerve sparing dissection, especially in this case, because we are talking about young patients. We are talking about patients who expect their pouch to work for 30, 40, 50 years. And it is very important to guarantee the maximum function for these pouches. I just wanted to show you the different kind of movements that you can reach with this. We have a pedal, as obviously the Da Vinci has, to switch from one pedal, sorry, from one instrument to the other. Can decide which hand of mine controls the reserve arm, because obviously we have 3 arms. That's another huge advantage of robotic surgery, right? So we have 3D video, which is great. And we have 3 arms. And another great thing is that we basically have back our vision, because in laparoscopy we have an assistant which controls our video. And obviously being our training hospital, but not always the most expert, and especially in difficult operation. So we have a big vein here. But the fact that we can control the camera exactly as we like, and you see that I can get forward, the focus is automatic. This is mesentery, you see the lymph nodes here. Obviously, this is not cancer, right? So I don't have to go to the origin of the vessel, because the origin of the inferior mesenteric would be somewhere like here, right? But I don't need to go here. I just need to free this space from one side to the other. And then I can just divide it using, for instance, a stapler as well. Why not? See that depending on how accurate was the previous surgery, it's possible to find this kind of adhesions on the posterior plane. So again, what I always insist on is for my colleagues not to get into the plane of the TME, right, which is this one. This is obviously the inferior mesenteric artery. You see that it goes here. We got lymph nodes here. Because the best thing when you do a proctectomy is to find this plane as a virgin plane, right? Because in that case, we don't have adhesions and we can spare as many nerves as we can. And you see that all these are nerves that we are gonna spare. How is the image? Can you see it properly?
Excellent.
Great.
I have a question for you. Is an
Yes,
excellent surgery, very elegant, and I suppose that with the robot you can go deeper in the pelvis. So
you have no
can
idea.
have a smaller rectal stump than
What I realized.
laparoscopy.
Yeah. I mean, you can go as deep as you go in laparoscopy, but the difference is that you actually see what you're doing. So as all my colleagues have done plenty of proctectomies laparoscopically, and especially in ulcerative colitis, we have to go very deep, right? We have to reach the plane, and afterwards I will show you the anatomical landmarks that we follow. But the point is, when you do it laparoscopically, especially at the very end of the dissection, you know where the anatomy is, but you don't really see it. While with the robotic surgery, you can actually see exactly what you're doing, even at the very last part of the proctectomy, which is a huge advantage. And again, you just use monopolar and bipolar. So this also forces you to stay on the anatomical planes, right? Otherwise it bleeds a lot and you don't want that and you don't see anything. So you can see the ureter was just done here, right? Do you have any question for me?
I have another question. I am very curious. When did you perform the colectomy in this patient? How many months before?
Well, it's usually, so in the, let's say in the standard case, it's about between 6 months and 1 year. So we want the patient to wait. I know it's not really, let's say the guidelines suggest to do it earlier, but we believe that especially in the patients that we see, they are so dramatically malnourished. They usually have tried all the biologics, and I don't think that just after 3 months, the patient is ready to undergo this operation, which is the most delicate one, right? So they have to be ready, you just have one chance, and you want the patient to be absolutely at their best shape. So let's say that in our opinion, it can be a bit old style, but I'm not old style, but you have to appreciate the old style when it works. I would wait at least between 6 months and 1 year. Well, talking about pediatric patients, which is a completely different thing. Sometimes the colectomy has to be done in emergency. We know that. So this is the plane that I developed previously. You see that I don't want to go too close to the origin. It doesn't make any sense. I want the nerves to be spared as much as I can. Let me just do this. And so for the pediatric patient, you know that we keep talking about when we should perform the second stage. And I think it is, again, a tailored discussion on the single patient. And as it happened, for instance, in this patient, we have to wait for the patient to be completely developed. It also sometimes a personal reason, you know, that they can wait also 10 years with the endoileostomy and the rectal stump in place. Sometimes they want to wait for their life to go ahead. Some patients female patients ask us to wait for at least the first pregnancy. We know that there is some evidence about impaired fertility in after pelvic surgery. So in all those cases, you can wait as much as you can. If the patient really wants it, the pediatric patient in particular, I would wait for the complete development and making sure that the patient is ready for surgery. We understand exactly what the surgery means because it's a big change of their life. So those patients are usually miserable when they reach the colectomy. They are reborn after the colectomy with the end ileostomy, but with the pouch there, especially after we close the ileostomy, it's a different thing, right? They have to get used to the number of bowel movements, to understand what continence means and how the pouch works. So we have to be ready that the pediatric patient is also mature enough to understand all these things. I don't know if you agree with me. Siamo una strutturatrice qua? Yes. So if you want to be super anatomical, you can dissect it. But since we are not at the origin, we don't have a single vessel. You probably saw it on the other end. This is the inferior mesenteric, which becomes the superior rectal artery, but we already have sigmoid vessels coming out. So I believe that it would be a waste of time to get just around any vessels and using clips to close them. And if you want to save time, as I usually do, especially considering our anesthetic time, we go with a stapler, a vascular stapler, which you can just put over the mesentery, and you just go with it. While I wait for the artery, I'm gonna play with the mesentery until it bleeds. Quite typical, right? Okay, you see that that's the artery, but we still have vessels, sigmoid vessels coming out. Is there any other question from the audience? No question, I would say. So this robot has been on the market for a couple of years. Properly, I would say 1 year, 1 year and a half. And they are still developing some of the optionals, which are not that optional. So the advanced energy, as I told you, is going to be ready in a few months' time. But we don't have yet the robotic staplers, which is a big miss. But it's not the end of the world, let's say. We can easily, we have an additional trocar. We always basically need, sposta la sutturatrice indietro. Need an additional trocar because you need to, the suction and the irrigation, you need to put hemolocks, you need to put a gauze in, whatever. I mean, you need all those kind of things, and you need the additional. Okay. So what we use in robotic surgery, inclina un po' a destra? No, dall'altra parte. Alza un po'. Ce la fai? No, alza ancora un po'. Inclina di più. Ok, fermo così. Guarda, fermo così, vedi che... No, fermati. Fermo. Vedi che sei troppo dentro. Vieni un po' indietro. Alzati. Spingi di più. No. Spingi ancora. Spingi. Ok, chiudi. So this is a, you probably know it, it's a Signa. So it's a Medtronic stapler. And the big advantage is that it's completely moved electronically. So it's a sort of a robotic stapler, obviously used by the assistant at the table. And it's great because what happens in robotic surgery is that, especially with this platform, but with all platforms, the assistant at the table doesn't have any space at all. They're very uncomfortable, and they don't have a big space to move from one side to the other. So what we need is this kind of stapler which moves very accurately, and that allows basically to staple everything that we need. So once you staple, you see that it's very secure. It's a 3-staple line, super easy to use. So even if this is the, let's say, the setting for the vessels, we can proceed with the section of the pelvis for quite a big tract. So we can actually do a bit of a TME. And again, you see the nerves here, probably better like this. And what I strongly suggest you to do is to save all these nerves, to pull it up, to make sure whether the mesentery go from one side to the other, and not just to go through it. And what happens is that I believe that when you use robotic surgery, since you don't have advanced energy, you can't actually go wherever you like, because the disadvantage of the advanced energy, the radio frequency of them, is that if you go on the wrong plane, it doesn't bleed, because the energy is actually good enough to stop it. If in this case you go on the wrong plane, it bleeds a lot. So it really helps you to focus on the anatomy and to the fact that you have to respect what the anatomy is. So in this case, I don't have a big range of movements as I would like here. Those sound is when I activate or deactivate the instruments, right? So I'm gonna just dissect it from here. And you see here the kind of view that you see, right? So instead of going here, you just stay very close to the mesenteric, sorry, the mesorectal fascia, which is here, right? It starts here. And you follow it. This is what you should do in rectal cancer as well. But in particular, in this case, you have to be 100% sure that the anatomy is well respected. This is a nerve, but obviously goes towards the rectum, so it's not something that I should spare, I believe at least. It's the lateral lymph node. And this is my plane, right? I think you really need to be obsessive compulsive here. So instead of going here, I want to make sure that this is not, and I think that we have to spare this, right? So this is a nerve, you see, it's also a big one, to be the hypogastric one. Since the patient is quite thin, the nerve is also very thin, and you want to spare it. Unless it's necessary to take it out, you want to spare it. So what we're gonna do now, we're gonna redock the system for the pelvis. It's gonna take about 5 minutes. In the meanwhile, you can do whatever you like, and I can see you here in when you're ready, or when Professor Lima decides. Okay.
So waiting for the following fantastic robotic phase, I am seeing on the screen Professor Paolo Di Coppie from Great Ormond Street, which I think is ready for his presentation. Paolo, are you ready? Yes, yes.
Yes, thank you, Giovanna.
Okay.
Good afternoon, Paolo.
Good afternoon, Professor Lima. Thank you
If you
for.
want, if you want to see that all the participants we expect in Bologna the next June, you are the president of the HELPSA, please.
Yeah, no, thank you very much, Professor Lima, Professor Icipeditoni, and all the organizer for the kind invitation. And sorry, I wasn't able to follow the whole meeting. What I'm being asked to talk about is about more stem cell work. We go from something very interesting, and I was very enjoying seeing the robot dissection, very accurate, to something that is more basic, but hopefully will help understanding where we are moving to in therapeutics for children and actually also adult. Just to set the scene a bit, we need to understand what is a stem cell. So it's a cell that can replicate in our body. It can cell proliferate, so to give rise to more cells, and can differentiate in different cell type. And this is classically what happened in the intestinal stem cells. We define different cell type because they can give rise to multiple different cells or one stem cells. And the one from the bone marrow are very similar to the one that are resident in the intestine. That's why I'm comparing them, because they are adult stem cells. So the adult stem cell, different from the embryonic, they can be derived from the same individual. So you can take stem cells from one person, amplifying them, and inject it back in the same person. That's what is very important for the intestinal stem cells. You cannot do that with embryonic cells because you can derive intestinal stem cells from embryonic cells, but those cells will not be able to be injected in the same individual. And if injected in the same individual, they need immunosuppression like any transplant. So when we are discussing the intestinal stem cells, there's an area that is very well defined in the intestine, both in the small and the large bowel. And when you have an inflammatory process, this area is particularly destroyed, and I will go more into that. But in the crypt, which is really the stem cell area of the intestine, both in small and the large bowel, you have different stem cells present. So at the bottom of the crypt, you have the stem cell compartment that have some proper stem cells and some cells that support those to grow. And then you have cells that are called transient amplifying cells, so cells that can grow and proliferate. And then you have the more specialized cells towards the end of the crypt. And this cycle is such that many people don't know, but within a week, you replace the old cells in your intestine. So your intestine replace the cells within a week, even in adult population. That's quite dramatic. And you understand immediately why, if you have a process of inflammatory bowel disease or so on, and this is impaired, that's really affect your bowel. So what happened in the situation of inflammation? You may have mutation that occur in these cells. This brings certainly an alteration of the tight junction. So there's this junction between cell and cells that do not allow things to be absorbed, or bacteria translocation and so on. This is normally in our intestine. When this is broken, and there are some protein like claudins, for example, they are tight junction, they are very important, then we have a situation in which bacteria can translocate and you can have infection or inflammation. And this is particularly important when you have some dysfunction of the epithelial cells. In particular, the globus cells are important in the intestine because they have this power of forming a mucous barrier. And if that mucous barrier that you see here represented in green is destroyed, that immediately you understand you can have an inflammation status. So the real stem cells that are present in the bowel are called organoid stem cells, and this can be easily derived by biopsies. So of course it can be derived from a surgical specimen, but also by an endoscopic biopsy. This can be derived, and you see first that you have the process of crypt isolation. So you have these cells that are present in the Petri dish as crypt, but those crypt eventually grow as single cells, and they form these nice, beautiful organoids. Are called organoids because they are mini organs. They can represent all the cells that I told you in the crypt, that are present in the crypt, and they grow like a little ball. So these balls tend to grow and form more complex organoids, as you see in the last picture, that even form little crypts. So they're able to really replicate all the different cell types that are present there. And there's been quite a number of years now of research on these organoid cells. And you see here some of the key experiments that really are important. One of the most important probably experiments is in 2007, the discovery of these LGR5 positive stem cells. So these are the true stem cells of the intestine that are present in the crypt, and the one that if we elaborate on a therapy for inflammatory bowel disease, those are the crucial cells that will be needed. So you will need to take either biopsy from a healthy part of the bowel and then growing them to then inject organoids. So this actually out of the press has just recently been done in Japan. So they've treated a limited number of patients. So that scale that I'm showing you here could have a 2024 in which they have done this patient with inflammatory bowel disease and with localization of in Crohn or patient with disease at the ileocecal valve, which is being injected with organoids derived from healthy part of the bowel, and those have been able to heal those inflamed part. We don't have yet the scientific data regarding those experiments, so we are waiting for those to be published, but it's being done recently in Japan. So the idea is that you can take these organoids, growing them, and inject it in vivo in the area that needs to heal. So you have an autologous therapy, so without having to use any immunosuppression. And this will be adapted for a number of patients that are refractory to any medical treatment, or for example, have fibrosis, which we do strictureplasty or other type of operation, or have recurrence post-operative. But also you can think about using those organoids as a vehicle for new treatment. So you can genetically engineer the organoid. So you take it from a patient, you modify some of the genes that are present that predispose to some of these inflammatory bowel disease, and then you can use these for injection and delivering of new therapeutics, or you can use mitochondrial therapy, again, using modification of the cells that are present. So in other words, we can think about a future in which we have an active area of disease, and so you take a biopsy from a healthy part of the bowel, you expand these cells, and then you create a stem-rich donor organoids that can be then injected in the refractory ulcer and put at healing the intestine. This is all what is happening, and this Watanabe is one of the team that in Japan is actually experimenting this in patients, and I'm sure more and more this will become important. However, many research has been done also using those organoids to understand the disease and create better therapeutic. So for example, doing personalized medicine using organoids-driven medication. So you can take organoids from the patient affected by this and expanding these organoids to test in vitro the potential of this when exposed to different type of medication, because it has been found that these organoids have different signature to the one of healthy individual. You can think about a targeted therapeutic that can intervene on those organoids specifically. So there are some signaling on the cells that makes this relevant important to the treatment. It's particularly relevant when we consider that there are drugs that are now evolved more and more that can target a specific mechanism of disease. So you can have pharmaceutical or targets that can be adopted to use in patient, but they haven't been tested yet. So you could consider a future in which you can have different organoids from different patients and then testing different drugs and see which one is more susceptible to this patient. So in other words, the organoids are really a reflection of what happened into the intestine in vivo. And also they can be used both for therapeutic or delivering new gene therapy, for example, or to test personalized drugs, so to make it more efficient to the patient. This is something that is very exciting, is coming, and is the way to go. The future is also related to the fact that you can use these organoids for expansion and for therapeutic in case you cannot recover the bowel. So in other words, you can use these organoids. You see an example here of the cells that grows over time, forming these organoids. And you can use, for example, gels derived from this destructurized intestine. So you can grow them on GMP, so in situation where you can transplant it in patient and expand these organoids for millions of cells, and therefore having organoids that can really be a target for patient. But you can use also these organoids for testing in medicine. So for example, during the COVID time, we used the organoids to verify that in children, the COVID was targeting the intestine rather than the lung. So the manifestation that we all here observe in children with GI symptoms, more than the respiratory symptoms, were due to the fact that the COVID had a trophism for organoids in children that was not present in the adult population. And ultimately, what we can use this is to engineer new tissue, as I say, for patients that don't have the possibility of recovering that. So with Vivian Lee at the Crick, we end up growing cells from different part of the intestine and showing that even after expansion, those organoids maintain the entity or the identity of the initial tissue. So jejunum, ileum, duodenum will still maintain, colon in the same way. These cells can be expanded and actually differentiate to form a functional tissue, and eventually they can be seeded on the intestine to form new intestine. And as you can see here, these cells can be seeded using bioreactor on the scaffold and forming new intestine. Even when you see the small bowel organoids on a colon tissue, you have formation of villi because these organoids really mimic what happened in vivo. So it's quite important that we understand as surgeons the nature of these organoids and the stem cell of the intestine, because certainly that will become a therapeutic in the future. Just to summarize very briefly, I didn't want to tedious too much research, but I think it's very important, this topic, and I really grateful to the organizers who have included, because in inflammatory bowel disease, this is coming a therapeutic already. At the moment in the form of the organoid injection, but also by using organoids in vitro to test innovative drug. And with this, I leave you all by remembering that with Professor Lima, we are organizing the next UPSA meeting in Bologna. So there's still time for people to subscribe and come in June in Bologna. And thank you very much again for the opportunity. If there's any quick question, I would be happy to take it.
Thank you, Professor De Copis. As always, a fantastic lecture. Look into the possible future scenarios. I don't know if someone has some question. Massimo, do you have any question? Please, you are muted.
Excuse me. No, I have no question for Paolo, only compliments, because your research through the years are improving every time, and is always very, not interesting, but really it's an enthusiasm that you give us, looking to these new frontiers of our research, of your research and of our research as well. So only compliments for this beautiful presentation. Looking forward to meet you in Bologna, Paolo.
Thank you, Professor Ivasecchi. I will look forward to see you in Bologna.
So congratulations again. It's difficult for us, all of us who are not really involved in such complicated research, to come inside the discussion. But we hope that as today we use mesenchymal cells for Crohn's disease, I think this is not only a new frontier, it's really very close as a clinical application. So thank you again, Professor De Copis. See you soon in Bologna with, I hope, a big number of participants of the live surgery group that are following us today. Bye-bye.
Thank you. Thank you, Professor Cipedisoni. Thank you very much again.
Now I ask the room, the robot, I ask the regia of Bologna.
Professoressa Cipedisoni.
Yes.
Professoressa, sono Michele dalla sala.
Sì, yes, I would like to come back to the robot.
Siamo pronti,
room.
siamo pronti.
Please, please, go on, go on.
Can you hear me?
Please go on.
Okay, so as you can see, the view is completely different now. So the camera is in the midline. It's just above the umbilicus. So we see the pelvis from above, and it's central. My left hand comes from the left side, my right hand from the right side, and my reserve arm from the left side as well. That's our favorite setup. And what we do here, we have to follow the holy plane, which means the anatomical plane between the mesorectal fascia, which is this one, and the posterior plane. And it's always important to stress that you never have to follow the hair, okay? Because the hair usually guides you in a plane which is not your plane. Because if I go here, I will sacrifice all the nerves, the presacral nerves which are here, which is not something that I want to do. So again, it's one of my stress, but you have to follow the mesorectal fascia, which is here, and you have to identify the planes, which is not always that clear. Also in ulcerative colitis, because as you can see here, there is some edema, big lymph nodes. That means that the rectum is still inflamed. It's always inflamed, okay? Even if it has been diverted for a couple of years, there is always some degree of inflammation, which also justifies the need for screening. Even if the patient has undergone a colectomy, those patients should undergo a yearly, proctoscopy. It takes 10 minutes. It's just the rectum. They don't need any preparation, but it's very important to make sure that nothing bad develops in the rectum while we wait to carry out So this is what I meant before, right? If you go here, well, just consider that you have a much worse vision than I do, because with the 3D vision, I have the sense of depth. So I actually see what I want, and I can see the triangulation of my instrument much better. Regardless, I will try to get closer because it's better also in 2D. So I usually suggest to develop the posterior plane first, and then the anterior one. And when you do this, you stay close to the reflection, which is here, between the mesorectum, higher up, and the ear plane here. And when something develops like this one, you just stay very close to the rectum. See, those are all nerves. There is a lot of edema. That doesn't help us, but still we have to follow it. So we don't go here. We go towards the mesorectum just to divide these the adhesions that we have. And we want to make sure that everything comes up. And even if we get into the mesorectum, it's not a cancer, so nothing happens. It can bleed a bit, but nothing, let's say, major happens. This is a bigger worry in oncologic surgery, obviously, because we can't divide or damage the mesorectal fascia. We know that it's associated with worse oncologic outcomes, but not in this case. That's not bipolar. It's okay if it bleeds a bit. As long as it doesn't bleed, what stays here. Okay, you see that now my plane develops in this direction, so it doesn't make any sense to go more lateral than this. Can you pull with the Babcock, please? So my assistant at the table has the rectum within a Babcock forceps. That is very important. What I suggest in robotic surgery is never to use your third arm as a steady traction control. You have to be able to move it, okay? It has to be like a sort of a counter traction arm. Otherwise, it's a waste. It's better to use your assistant at the table with a forceps to get there and to like in this case, for instance, to mobilize the rectum up. You see a lot of edema here. It's always better to develop the plane posteriorly. You see, this has to go down. It's inflamed. I know that it can bleed. It doesn't really matter. I want to spare it. This is that's my plane there, okay? The counter traction is always essential. Like this, okay? So that's mesorectum here. And always want to save and spare the posterior plane. That's the most important thing that you have to achieve in this operation. Once you've done that, you can follow the anterior plane, again, layer by layer. And you reach what you have developed posteriorly. So the experienced robotic surgeons, which I'm not having, usually tell that you have to see just the tip of the instruments when you do robotic surgery. You have to be very, very close. And that helps you because actually you get much more accurate. Obviously, you see better the planes because the 3D gets better and better the more you get close to the planes. And you can see here, you can see these reflections here. And I can just pull them down like this. Okay. And but also the accuracy of your movements is much, much better. See? This is my plane. It's okay to have some kind of adhesions. It's due to the inflammation, even if the patient is very young. See, that's my plane here. See, that's my plane, you see? So if I push this down, I can see that there is a space here. That's what I should try at least to follow. Oh, sorry.
The dissection looks very nice, but I want to ask if we can come back when you have finished the rectal dissection.
Oh, sure.
And now is Professor Giunchetti there with is connected? Do you know if Professor Giunchetti is already connected? Michele, could you help me, or Tommaso?
Professoressa Ricipetitoni?
Dimmi, Michele.
Giunchetti sta andando nel suo studio, si sta per collegare.
Ok, perfetto. Quando lo vediamo,
Sì.
diamo il floor, perché sennò si fa tardi, insomma. Poi facciamo
Sì.
in modo di riprendere, appena finito ritorniamo sulla presentazione, sulla sala. In sostanza.
Sulla sala, perfetto.
Esatto.
Ok, bene,
Ok,
a dopo, grazie.
Ciao, mi sentite?
Yes, Professor Giunchetti, are you here?
No, scusate, ma ero in giro per le parti.
So,
come sempre. Allora, vi carico la mia presentazione, condivido lo schermo. Metti in presentazione.
So, it's a pleasure.
Vi occupo poco tempo. Vedete le slide?
Certo, certo, certo.
Did you see the slide?
Yes, we can see very well. I am delighted to introduce Professor Paolo Giunchetti because Professor Lima is now doing a university lesson. So he is the most expert in Italy in adult IBD. So please, Professor Giunchetti, go on.
Okay. Thank you very much for inviting me. So we are speaking about IBD. IBD, we should not forget that these are disease that they are lifelong disease, and so we need to manage the patient for all life, and so our strategy should be lifelong too. So we have to think not for 6 weeks disease, but for a disease, a chronic disease, and we have to think about our choice at the beginning, for thinking also which is our aim, what our objective for the long term. These are progressive disease, very heterogenic disease, so with possible hospitalization, surgery, especially in Crohn's disease, less in cervicalitis. They have could be comorbidities, extracerebral manifestation. Also, the risk of cancer is increased in respect to the general population. But the cumulative burden of IBD patient is not only that. We have to think about these people are very young, they have a long life, they have a lot of problems, also personal problems regarding the physical well-being, concern for family, psychological problems, problems for the job, the expectation for the future, financial consideration, many other problems that are very heavy for this patient. This is the two diseases have a very peculiar clinical course. This is a study from Ipsen. It's an old study, but it's still very important because what they showed in this study, they showed that both in ulcerative colitis and Crohn's disease, there are about 50% of patients with a mild clinical course. We have another half of patients with a very aggressive, chronically active clinical course. So this is important because there are important implications for therapy. The great revolution we had in this field has been the introduction of infliximab. You know, this is the paper published in New England 1997. You can see a very images from Crohn's disease, very active, very severe Crohn's disease, and the results after only one infusion of infliximab 6 weeks later. From that point of view, that time, a lot of new drugs have been developed at the entry of the market. So we have now a very large armamentarium in our hands. And the problem is that now to choose the right patient for the right drug for the right patient, which will become, in my opinion, more difficult in the future. We have now anti-TNF, infliximab, adalimumab, and then golimumab for ulcerative colitis. We have anti-integrin vedolizumab, and now available also as a subcutaneous infusion. We have ustekinumab, which is an anti-interleukin 12/23. We have now available 3 small molecules, which are anti-JAK drugs, oral drugs like tofacitinib, upadacitinib, and filgotinib. And then just now entered the market mirikizumab, risankizumab, and next year we will have guselkumab, which are anti-interleukin 23. So an evolution of ustekinumab, selective treatment, which have been shown. All these drugs have been registered with pilot study, by pivotal study. We confirmed the efficacy of this drug against the placebo. But obviously, in the last 25 years, having available all these drugs, we changed our goal of therapy. We passed from only symptom control to try to have a disease control. So now, in my opinion, the most important goal of the therapy should be remission without steroids, which are still used too much in this patient. And particularly important for me is the mucosal healing. I will so wipe histological healing. Obviously, in the future, we will trying to obtain all histological remission. There are some studies published recently that show that, especially in ulcerative colitis, having histological remission, that means that we'll have a better clinical course afterwards. But pivotal studies are for the clinical trial, registered in the clinical trial, they do not represent the patient we saw in our outpatient clinic. Only 31% of our patients could be eligible for a clinical trial with biological therapy. That means that real life data and real life are really very important to understand the real efficacy of the drug and the possibility to have the best choice for such a patient. This is a recent published study with a consensus of many experts. This is looking at the treatment targets in ulcerative colitis and also in CD, in Crohn's disease. In my opinion, endoscopic healing, especially for ulcerative colitis, cannot be considered a long-term target. In ulcerative colitis, we have to obtain this endoscopic healing early, very early. could be long-term targets in Crohn's disease. And so after 1 year, we treat the patient with a biologic, but not in colitis. So we cannot have the same treatment target in both diseases. It's also not for all patients. I think we have to find a target for a specific target for the specific patient. Mucosal healing is very important. Why? Because we know from the literature that there are, when we obtain mucosal healing, we have a lower relapse rate, lower clinical recurrence in post-operative Crohn's disease, lower hospitalization rate, reduced need for surgery, lower risk of colorectal cancer in UC, lower relapse rate following drug withdrawal. So I think this could be the most important target for both diseases, especially for ulcerative colitis. When we have a patient with IBD, so we have to choose the right treatment. So for doing that, we need to know very well the patient and the disease and the symptoms and the localization and everything. So we need to choose which is the best treatment for that patient and try to treat early those patients who will have an aggressive disease compared with those who have a clinical course, mild clinical course. Always our treatment should be aimed to aim at to obtain the mucosal healing, at least mucosal healing. This patient also to be monitored regularly. In case of in this kind of monitoring would be useful because it can help us to choose the right moment to change the drug if the drug is not we choose the first time is not working, to optimize the drug in case the drug is active but only partially, or to stop the drug when we obtain the deep remission without for at least for 2 or 3 years. So the possibility to try to avoid to over treat the patient for longer time, because over treatment is also a risk conditioning a lot of side effects. And these are all the drugs we have now available for treating our patients. Without forgetting, I put also surgery as a treatment, because there are some patients in which, like the patient before presented by the colleague in Parma with a stricture with only few centimeters of terminal hilum with disease, we never use biologic in that patient. Because we know that if using biologics, we can obtain mucosal healing, but can also determine an increase of the risk of surgery in a shorter time, with respect with the use of less aggressive drug. So I think for doing that, we need to know the patient. This is just to show you how we changed our behavior in patient with Crohn's disease in Europe. You can see there are 5-step, corticosteroid, immunomodulator, biological therapy. In the last 5 years, this study has been published in 2018. So from 2013 to 2018, comparing Eastern Europe with Western Europe, in Eastern Europe, the use of biologic was very, very low, like 12%, compared to the 30-35% we had in Western Europe. But looking at the results, hospitalization rate, complication, and need for surgery, these were not changes in both groups. That means probably we use this drug in Western Europe, but not in the right patient, because we use larger, we had larger use of biologics, but the results at the end were similar to that country where they use more conventional therapy. we have to think about that. Another example of that is the study REACT-2, in which in more than 1,000 patients, real life study, have been compared to two approaches. The step care using a conventional and sequential therapy based on a treatment intensification based on symptoms, compared with the enhanced care, so using early combination of therapy with biologic and immunosuppressive therapy. If you see the two groups were comparable from a clinical point of view, at the end, the results as regards the PD-related complications were similar in both groups after 2 years. That means that probably is not correct to use an aggressive treatment or step-up treatment in all patients. So we have probably learn more and more which patients to be treated aggressively and which patients can be treated with step-up approach. Another example of that is this study, large study published in 2020 from the United States. You can see about 30,000 patients in New Zealand, and I think there were 16,000 patients with Crohn's disease. The use of, at the beginning of biological therapy was 1% compared to all the other drugs, and the use in the follow-up, the years after starting therapy of biological therapy increases to 6% in ulcerative colitis and to 12% in Crohn's disease. That means that nevertheless, we have very powerful drugs we use in very few patients, and probably not in the best patients for that treatment. Probably when the disease is too difficult to treat, so when there is already a strict cure, when it's too late, probably. That's we have to take this kind of approach. So we need to, I don't know, okay. So we need to work looking at the patient. The patient has to be at the center of our attention. That means because there is no one drug that could help all. One approach, one strategy can be.
Excuse me, Professor Giorgetti, excuse me. We can't see your screen anymore. I don't know if there is a problem of the regia or not. We are looking.
I don't understand. Can you speak? I increase the volume.
No, but it's not the volume. We have no
slide.
No
Okay.
slides on your.
Okay,
now they appeared again.
Okay.
Thank you very much.
I don't know what's happened.
No, it was recent. It was the last. I think it was the last.
Okay. So there could be not one strategy for all the patients, and each patient is different from the other. So we have improved our treatment in this patient. If we have to choose which one patient should be treated more aggressively than patients that can be treated with a step-up approach. For doing that, if we want to obtain a deep remission, we have to do a deep evaluation of the patient, both at the diagnosis and or restaging time. So we need to do disease localization extension, previous effectiveness or refractoriness or intolerance to other treatment. If we are treating an initial presentation of the disease or relapse of the disease, the frequency and the severity of relapses, the presence of intestinal manifestation, if the patient is steroid dependent or steroid refractory, we have to evaluate very well and weight very well the risk of therapy. And also, obviously, if a patient has a relapse while he's on immunomodulators or biologic, this relapse should be considered much more severe. For doing this work, we have to involve our patients. They should be empowered to participate in the decision-making process, because sometimes our objectives are different from those of the patient. So we need to improve our approach in this sense. And probably at the end, when we evaluate very well the prognostic risk of each patient, we can choose from when the disease has an clinical course, indolent clinical course, we can use the step-up approach, avoid intensive therapy, immunosuppression, and adverse events. When there is a disease, on the contrary, a disease which is very aggressive because it's very expensive, because there are deep ulcers, because the patient is, for chronic disease, a smoker, because the patient has been already operated on. There are many risk factors that we can evaluate. In this case, we should treat the patient in a more aggressive way with the top-down approach, trying to treat the patient with the most effective drug to avoid complication in the future. So whatever is the treatment we start and we decide to use, we have to always have in our mind which is the aim of that treatment, because it's destroy discontinuation, to bring the patient in deep remission, control of extraintestinal manifestation, healing of a fistula. So we need to ask ourselves why I do this treatment, which is my objective point of my therapy, because this is important for choice of therapy, duration of treatment, time point for reassessing the patient, choosing which examination to use to monitor the patient, and stopping or not when, if there is a possibility, or changing biologics or drug when this drug is not doing what we expect. And we should not forget that the patient is not the patient that failed the treatment, but it's the treatment that failed patient very often, in the sense that probably we fail patients because we use the wrong treatment. As I show with the results from population studies that showing that we are not changing the natural history of this patient. And we have to put always on the other, we have to balance the risk and the benefit. We should not forget that since we introduced the biological therapy, now the mortality is increasing in those patients, but not for the disease itself, but for the complications that derive from the use and abuse of this drug. We should not forget that we have to work with our patients to be a partnership. We have to choose a treatment based on trying the best treatment to obtain mucosal healing, which have a good profile, safety profile. And also, so we have to choose the treatment considering a predictor of outcome. And the patients to be informed, better prepared to talk with clinicians. They have to understand pros and cons of different therapeutic options, and they must participate on the plan and the choice of the drug. So we have to partner with our patient, we have to empower the patient with our choice. Because also biological molecules do not solve the impossible. So my message is that we need this drug. We are very happy to have this drug, but we have to use this drug at the right patient, choosing very well, thinking about also the risk they can have from this drug. And we'll finish with this slide that for me is representative of what the message I want to give you with this lecture. Thank you.
Thank you, Professor Gianchetti. I think the idea to have a targeted therapy for patients is the winner therapy today. We have a question from the floor, Dr. Riccardo Coletta from Florence. is asking us, can you discuss the challenges related to immunogenicity in pediatric patients receiving biological treatment for Crohn's disease? And what strategies are employed to manage or prevent the development of anti-drug antibodies?
So the problem of immunogenicity is prevalently peculiar of the anti-TNF drug. Now we have a lot more drugs available which have less problem of immunogenicity. For anti-TNF, especially for infliximab, at the beginning we used the combination treatment with immunosuppressive for this reason, for reducing the risk of immunogenicity and formation of anti-drug antibodies. Now we don't use anymore the combination, both because the risk is increased, safety risk are increased. And second, because we can avoid the anti-drug antibodies following very well the patient and trying to optimize the treatment when we have you know, the sensation of losing the response. The drug is losing the response. The problem is you follow, is the monitoring that is most important thing in those cases. If you do treatment, if you, before every infusion or regularly, you monitor the patient, the drug, the blood examination, or doing ultrasound or endoscopy when there is the right moment, always you can understand if they are losing, the drug are losing their efficacy, and you can manage that reducing the interval from the infusion, so optimizing we recently published a paper also on optimization of antibody, anti-TNF. This, in most cases, you can recover the response from the patient. In the case also after optimization, you don't recover the response. You have to swap this therapeutic approach. So you have to change the drug. And now we have available many other drugs which are less immunogenic that they can be used without using immunosuppressives together. And so more safe, and probably this is the right. It will be the future. Will be the future.
We learned a lot from your adult experience, and it was really very important, very educative for pediatric surgeon and pediatric expert too. Massimo, do you have some question for Professor Giocchetti?
Professoressa, sono Michele.
Michele, vi stiamo seguendo sullo screen, vi vediamo perfettamente.
Sì, siamo anche pronti per un commento, se volete.
Okay. So, thank you, Professor Giocchetti, and we move
Thank you,
to
Professor
surgery.
Giocchetti.
Thank you very much. Bye-bye.
Bye-bye. So we are ready, Michele.
Okay.
Hello. So basically, we have done the rectal dissection. The anatomy here is very clear. The rectum was quite inflamed. You see all those lymph nodes, which is obviously a sign of inflammation. There was a lot of edema, and the plane was not always that clear, which often, basically always happens when we do these proctectomies. You see that the mesorectum always bleeds quite easily when you touch it because it's inflamed. But this is what you want at the end of the dissection, right? So the presacral plane is all preserved. All these nerves are preserved. This is the levator ani, so the pelvic floor. And you just dissect the rectum up to this level. You don't need to go lower down because otherwise we would damage the levator ani, so which is essential for continence. We are well below what we need to where we need to go. So just let me check here anteriorly. We're okay. That's this part here. That's the wrong button. So that's what the dissection is, okay? So this is the vagina, and we have reached this level here. You see that there is no mesorectum here, which means that the mesorectomy is done, it's finished. This is just the anal canal. And we don't need to go any further. There we are. So I'm going to show you something. So we started with laparoscopic colectomies many years ago. When I arrived at Sant'Orsola, it was 8 years ago. And since then, basically all the colectomies have been done laparoscopically. But when we have to switch from open pouch, open proctectomies to laparoscopic proctectomies, we realized that the laparoscopic staplers are not adequate in reaching what we want to do when we have to divide the rectum. And I will show you why. So now Giacomo is gonna put the stapler in. So this is a laparoscopic stapler, okay? It's the same that we use for the division of the vessels before. And go back a bit, Giacomo. So what we want, ideally, is for the rectum to be divided here. And it has to be divided perfectly perpendicular and possibly in just one file. But you see how narrow the pelvis is. So this stapler, this is a 60, we can use a 45, but it doesn't really change. Even if we articulate the stapler, we'll never be able to put the stapler at this level and to fire the rectum perpendicular. Why is it so important? Because we have to make sure to remove all the diseased mucosa, otherwise the patient will have a long cuff and the caffitis, which is a major complication after this type of surgery. And if it is uneven, so if it goes like this and not perpendicular, we'll have too long a stump from one side and too short on the other. So we'll damage the sphincter on the other side. So until we figure out how to overcome this difficulty, we didn't start any laparoscopic procedure. And I will show you in about 5 minutes how we overcome this problem. So we're gonna take the instruments out. We're gonna undock the robot because the robotic part is finished. And I will show you how we perform the proctectomy. So the division actually of the rectum and the pouch formation. So if you're okay, we'll call you again in about 5 to 10 minutes.
In this period, I will be delighted to show you a robotic colectomy made by the general surgeon in our institution. I try to share the screen, just a minute, because I need to do, I need some time. Okay. Okay. So I go there, share the screen, condividi lo screen. Okay, it's right here, condividi. I hope to be able to open. Yeah. So I try to go quickly just to the technique, because I think it is the most interesting part. So this was a patient .
Johanna.
Sì?
Dove sei?
Sono qua, mi sentite?
Sì, ti sentiamo, ma vediamo solo la tua schermata, diciamo.
Ah, ok, hai fatto bene a dirmelo, scusa, interrompi condivisione. Quindi non avete visto il video in sostanza?
Io no, perlomeno. No.
No, aspetta, riprovo di nuovo. Adesso lo vedi?
Adesso vedo un video, è il tuo questo.
Sì, è il mio video. È quello della colectomia robotica.
Sì, ho capito.
Si vede?
Sì. Vedo tutta
Posso tornare indietro un attimo, magari, aspetta. Ritorniamo indietro
sia al momento
all'inizio.
in cui entri?
Sì, questo. È chiaro adesso? Lo vedi, Massimo?
Sì.
Grazie.
Adesso sei uscita.
Non si vede più?
No, si vede una sala.
Allora non so cosa dire, perché io lo vedo. Forse è la regia di Bologna che non lo fa vedere, non lo so.
Questo che cos'è? Questo sei tu o sei Bologna?
Questo sono io.
Ok. È una donna, una femmina.
È una colectomia.
Sì, dico in una ragazza.
Professoressa Ripetitoni, I have Tommaso, but we don't see your
You
video.
don't see. Okay, you don't see. Okay, I stopped. So now I can try to share again the screen.
Yeah.
The video is right there.
Yeah.
So, aspetta, posso aprire anche di più the video.
Okay, now I see your laptop.
Yes, I know, but just a minute, I have to come back because la condivisione si è arrestata. Aspetta un attimo, adesso non lo vedo più neanche io. Un secondo, devo tornare indietro perché non ce l'ho neanche io adesso sullo schermo. Un attimo, lo riapriamo, si è chiuso. Pugliese, ecco qua. Lo mettiamo di giù in piccolo, il video dovrebbe essere di sotto. No, non lo vedo. Aspetta un attimo. Il video è qua, quindi adesso c'è. Adesso proviamo a condividere e a vedere se lo ribecco, se no lasciamo stare. Era molto carino, ma prima, ecco, condividi. Adesso dovreste vederlo. Lo vedete? Io lo vedo.
No, professor.
Non lo vedete.
We see your laptop. You see your laptop.
Ok, lascia stare allora, guarda, non stiamo diventando matti a quest'ora. Aspetta, mi spiace, ma non so cosa posso fare di più. Perché... Ok, aspetta. La condivisione si è chiusa. Strano perché ce l'ho qui sul coso, aspetta. Faccio un ultimo tentativo, Ce l'ho sullo condividi schermo. Ce l'ho, adesso è sparito anche dal mio di nuovo, Non è così semplice probabilmente perché ce l'ho in una cartellina che è qua, vedi? Adesso io l'ho aperto, aspetta, vediamo se riesco a metterlo in piccolo. Sì, proviamo a vedere di riuscire a aprire.
Assomiglia a Mario.
Aspetta un attimo, aspetta, condividi.
We see your laptop now?
No, niente, va bene. Quindi non vedi il video, lasciamo stare, chiudiamo e via. Se non lo vedi non ci posso fare niente. Cioè ce l'ho, ma se non riesco a mostrarlo non ha importanza. Hello. Andiamo da voi che stanno facendo la stapler.
Okay, so this is the operative field, okay? We got two Alexis retractors here and here. This is where we got a bit of echo, sorry. Yeah, it's better to use the earplug. And we had the ileostomy here and we had the rectal stump here. So we mobilize them, we put them back inside the abdomen, and we go ahead. So to overcome the problem that we discussed about earlier, so the fact that we are not able to divide the rectum, we came up with a very easy solution. So this is a TA stapler, okay? This is what we have been used in the world for tens of thousands of procedures, and it is very effective, and it's quite unique because, as you can see, you can apply the staple line perpendicularly. It's a 30 millimeter large, and no other stapler is this short. It's able to go above the rectum and to close the rectum like this using this pin. And then when we close it, we are able to close it exactly at the level that we want and exactly perpendicular to the rectum. The point is, this is not a laparoscopic stapler, it's an open stapler. So in order to do this, we find that the easiest solution is this one. So we cut a glove, we put the stapler inside the finger of the glove, we remove this, which is the Alexis stapler, we put the stapler inside with the glove over it, and the glove is obviously used to hold this for me, please. Hold this. It's used to restore the pneumoperitoneum, right? Otherwise, we won't be able to go back in laparoscopy in this case, or robotic surgery. So we can, possiamo accendere l'ERC? Perso la cuffia. Okay, so now we're going to restore the pneumoperitoneum. And you see that it's very easy. And if you're happy, we'll go back with the inside camera. Yes, it's good. It's sorry guys. We can use the air seal here. Air seal. Troca il air seal. Just give me 1 second, please. Con l'introduttore. Okay, just give us 1 second to restore the pneumoperitoneum. No, 8 point. Okay. So we're gonna wait to have the right pressure. Metti la pressione a 12 per favore. Oh, scusa. Pressione a 12. Grazie. No, dall'altra parte. Ok, quella. Grazie. Ok. Okay. Okay. Camera in. Porta. So I'm going to show you how we have performed the last, I think, 250 division of rectum, laparoscopically or robotically. So give me Babcock, per favore. And Joan. So we have to pull the rectal stump up like this, all this, yes. And then we open the TA. And as we do in open surgery, sorry, di qua per favore. Okay, as we do in open surgery, you see there, good. We have to put this just like this, and like this, and then here, like this. So once this is over the rectum or up the canal, we just have to slide like this. So this is how this staple is designed, okay? And as you can see here, once I apply this, I can divide the rectum above, show me, exactly as I want. You see? Obviously I'm rotating the stapler, but this is completely perpendicular. I am very close. This is vagina, just above here. And I'm even a bit too close, because I want to just have to remember that we're going to need about a centimeter at least for the anastomosis. Back. Good. Show me that. That's good. That's good. Okay. So the first file is just to close it. The second one, which is this one, is to apply the staplers. The only disadvantage of these stapler is that it's an old staple. It's very thin and it doesn't cut. So it secures basically only the distal staple. Yeah, only the distal stump. But it doesn't really matter because the rectum is supposed to be prepared and clean. So I can cut it like this. Now the most cutting scissors here. This is a vessel which it's okay, it doesn't really matter. If you don't like this, you can put another stapler on the other side. Okay, good. Okay, now we hold this higher up like this, suction, actually. This is just a residual blood in the rectum. It's okay. See that there is nothing bleeding in the pelvis. Okay, all good. And once I release this, the rectum falls higher up. It's okay for the rectum to bleed. This bleeds a bit too much, but we're going to do some hemostasis now. Elettrico a noi. Mi fai vedere cosa sanguina, per favore? Puoi mettere una pinza dentro di te. Ok. Alzati su piano piano. Ok. Qua. Vai, brucia. Sorry, vai. Let's try this. Vai. Okay. Fermo. Vai. Non sto toccando davanti, vedi, torna indietro. Vai là. Vai. Vai, senza paura. Ok, vai. Ok. Dammi una garza. Come vedi il cingolo? Chiuso le 5 per 95. Metti là. Spiratina. Dammi una garza. Insieme. Guarda in su. I'm gonna put some pressure. Again, no worries. It's just the start. And if you're happy, we'll connect again in about 10 minutes once we perform the pouch from outside, okay? Torna indietro. Grazie.
There are some questions from the audience. I don't know if we can do, Mario. They ask, Coletta ask if the robotic stapler can be better.
Sono Michele. Stanno un attimino riassestando il campo operatorio, quindi abbiamo qualche minuto di pausa. So, volete?
So Mario, if you want, I can give the floor to my young trainer, Carlo Ferlini,
Yes.
who will present the case of terrible case of ulcerative colitis. Vieni qua. I give him my computer too. Prego, più sicuro, please, go on.
Okay. Is the Ferlini days.
Poi non sono riuscita a mostrare il video, dopo vedere se tu sei capace di farlo. Quello di Pugliese, che era bellissimo.
I say that is Ferlini days. My compliment, please.
Thank you.
Si cuoce.
Now I'm going to show you
Dai, parla
the
pure.
presentation. Just a little
Ecco,
patience.
devo andare sopra.
Sì, devo mettere la cosa qua. Sì.
Ah, ok.
Allora.
Ok.
Okay.
Vai nella sala robotica e adesso condivido.
All right, I'm going to share my screen. There you go. Can you all hear me and see the presentation?
Hai la voce?
Yes, we see well.
Perfect. So I'm going to talk to you about this terrible case of ulcerative colitis we happen to follow for over a year now. And that's how it goes. Our patient is named Andrea. He's aged 15 years, and he had no previous history of chronic illness. He was in habitual full health with an active lifestyle. Actually, he was the captain of his football team and very proud of that. No dietary restriction and non-smoker. Also, from his family side, there was absolutely no family history for inflammatory bowel disease. So how did Andrea came to our attention? On May the 12th of the last year, 2023, he had his first access to our emergency department for profuse diarrhea would not stop. And he was discharged. But after a few days, on May the 15th, he had a new access for vomit, diarrhea, and fever. So this time, fecal exams with calprotectin and cultures were taken and sent to the laboratory. The following day, diarrhea absolutely would not stop, was very profuse, this time with blood. And he was hospitalized in the pediatric ward due to his age, where Clostridium and calprotectin both came out positive. So an antibiotic therapy was established. His condition did not improve, and he underwent a general screening to see his abdomen. So the ultrasound showed an augmented thickness of the colonic wall evident in all segments, with presence of peritoneal fluid, but small bowels were apparently normal. And when an X-ray was taken the same day, the colonic air distension and a very big edema was observed. On May 23, he had an important lower intestinal hemorrhage with anemization, which required his first red cell transfusion, which was not going to be his last. And since the clinical picture had no signs of improving, a decision was finally made to perform an endoscopic examination, which I'm going to show to you now. It was taken the following day. Gastroscopy was negative. A diagnostic laparoscopy was performed. It was negative too. But colonoscopy showed signs and was very strongly suggestive for ulcerative colitis with a picture of Mayo 3. So here's the video. As you can see, there is widespread mucosal ulceration. Here you can see the lower reaches of the intestinal tract and going up, no folds, a lot of blood, and this for all the length of the colon. A near identical picture. You can see the enormous amount of blood is very evident.
Gotcha.
Okay. So we decided to start monitoring his daily PUCA score, which was constantly between 55 and many days even 70. And we started looking at guidelines to decide what to do with this patient with such an aggressive case of incipient ulcerative colitis. So we looked at the guidelines, and first they urged for intravenous methylprednisolone, C how the clinical response was, and take the following considerations after a careful evaluation on day 3 of the PUCA score, which, as I mentioned, was very high in this case. So its clinical picture had no signs of remission even after therapy. And we had the provision that if the PUCA score was constantly high, after a few days, we would have to take a decision. So to start infliximab, see if it would respond, and if not, consider a colectomy. So how did the following days go? We started with methylprednisolone, 40 milligrams for 3 days. Then we had a little decalage to 30 milligrams in association with very strong antibiotic therapy, as you can see, vancomycin, ciprofloxacin, metronidazole, total parenteral nutrition, of course, because it was under total fasting, and a prophylactic low molecular weight heparin. But the bleeding continued nonetheless, with several episodes a day of abundant bloody stools, which required periodic blood transfusions. So since the PUCA score was constantly high, we started infliximab to administration of this medicine, as you can see. The only effect this had was decreasing the number of daily stools, which was before infliximab 3, 4, maximum 5 times a day, to one single very big discharge once a day, but that discharge was about 1 liter of material. So his blood loss was constant. It required 13 blood transfusions in a period of just over 2 weeks. We decided to have one last colonoscopy to decide finally what to do, which you can see here. Absolutely no change. Still a lot of blood, still mucosal ulcerations all around, the same dramatic picture. So at this time, we thought therapeutic options were not efficient, not infliximab, not steroids, and even if the mother in the first moments was quite reluctant, she had to accept the truth too, and so we had to perform a proctocolectomy, which was performed on June the 12th, with also a terminal ileostomy. There were no intra- or postoperative complications, and he was discharged home after 2 weeks with oral feeding, which was well tolerated and modular. At home, he pursued the therapy with mesalazine rectal gel, metronidazole in vaginal preparations, the small ovules to insert in the anus, iron, and the B12 vitamin supplementation. In the following months from the operation, he had some sporadic bloody discharge from the anus, sometimes very abundant, but nonetheless it was in quite good health. And he had an excellent weight gain because he had lost a lot of weight from the first intervention, up from 56 kilos. And he went to 72 kilos over the course of 6 months. After this period, we decided it was the right moment to perform reconstruction with an intestinal pouch, ileal pouch, and anastomosis after mucosectomy. But we decided to maintain for the time being the ileostomy for protection. And finally, in February 2024, we performed the closure of the ileostomy after previous anal dilations prior to closure. He lost again a lot of weight after these repeated interventions. He went down another time to 54 kilos, but he was able to get back quickly from this intervention. And on April the 12th, 2024, he had his first pouch endoscopy for control, which showed no erosions, no bleeding, and just a mild phlegosis as histological examination. So that's where we are right now. He is following home therapy of metronidazole 7 days for a month, and supplementation with dobutin, cholestyramine, and talifer. His weight is currently 58 kilos and finally increasing after a period in which, despite moduline and an aggressive alimentation therapy, he struggled with that. From the point of view of his continence, he goes to the toilet about 7-8 times a day at night with minimal sporadic discharge, which is always followed by awakening and voluntary defecation. The most important thing is that he still has his continence because he can feel the stimulus and voluntarily delay defecation. He tells us that this is not a problem for school, for example. He's able to perform his routine activities, and he has started again to play some football, which is his real passion. So that's where we are. I thank you for your kind attention, and if you have questions, I'm open to that.
Thank you very much. There is question from the audience.
May I comment?
Yes, Matthew.
Just 2 words. This case reminds me a case, a girl I have been operating on the last century, at least 30 years ago, 25 years ago. And she arrives, she was doing a lot of therapy, like at that time they were doing cortisone and cyclosporine. At the very end, she was passing stools with blood, quite a lot of blood. She arrived to our hospital with 4 or 5 of hemoglobin. So I was obliged to do the same thing that you have done. I did a colectomy, closing the rectal stump very down in the pelvis, doing an ileostomy. And after 6 months, at that time I was doing the straight ileoanastomosis. So she had to fight a little bit with her continence. But now I just, time by time, I have news from her. Now he has 3, 4 stools a day. She's a young lady, enjoying life, having a boyfriend and so on. What I want to say is that this case happen. They can happen. And when they start bleeding in that way, we surgeon, this is my opinion, we surgeon must face the willing of the gastroenterologist that want to go on with medication. But sometimes the medication are not so effective. So the colectomy at that time become as an emergency. And even if in literature, you can find that someone, and when I say someone, I refer to Arnie Koren, for example, they've experienced the ileoanastomosis in the same moment of the colectomy. My advice is to work as you have done, colectomy, wait, and then the ileoanastomosis that today I would do with a J pouch as well. You have done. Thank you.
Thank you very much, and thank you for your kind insight. I leave the floor to Professor Ricci.
Okay.
Now, Giovanna, if you agree, we do the complication corner.
Okay, I completely agree.
Tommaso Gargano.
I try to share my screen. This is much, okay, oh, just a moment. Come faccio a chiudere questo adesso? Aspetta, chiudo questo. I need of the help of my... ok.
No, andiamo ancora avanti.
Devo mettere esca, se non metto in piccolo questo non riesco adesso. Ok, questo lo chiudiamo because I had the invasion from my from my young trainer. All my young trainer are really very nice, I have to say. They are all very nice. Adesso li sotto, questo lo mettiamo qua così. Ok, now I try to share my screen. And I hope complication. Okay, it's fine. I'm sorry that I was not able before to show my video, but I think there was some problem in the video. Okay. Could you see my screen?
Yes, yes,
yes.
yes.
Okay, okay. So speaking about complication and recurrence corner is not easy after such a big experience presented by Professor Poggioli. I have to say that I took some picture about the complication that he presented, so it could be useful to come back to the point that he underlined during his presentation. When we speak about complication of recurrence, we have to speak also about the outcome, how we evaluate the results. We evaluate the results about the number of toilets in the first year after the intervention, about presence of daytime or nighttime fecal continence, as Massimo was underlined before, about the need of postoperative medical therapy, and about the need of new surgical procedure, not only for recurrence of the disease, as it can happen in lung disease, but for complication. So one of the major complications is related to ileal pouch complication. There are a lot of literature about this point, and they can be postoperative pelvic sepsis. And also the patient with pouch can develop pouchitis and can develop also due to inflammation, also dysplasia and carcinoma and cancer of the pouch or of the rectal cuff or of the anal transitional zone. And for this reason, they require a postoperative endoscopic surveillance. These are the ECHO-ESPGHAN guidelines, where there was a consensus about some recommendation. And the recommendation are then when we suspect a pouchitis, we have to do an endoscopic study of the pouch, and there was an agreement of 94%. If we detect an inflammation, 2 weeks ciprofloxacin and or metronidazole, mainly both, are recommended as first-line therapy, and with 100% of agreement. And in persistent cases, we can add the budesonide that can be used locally, and also probiotics. Probiotics are recommended for maintaining the remission. There was also a nice paper published by Professor Gianchetti on the role of probiotics. And topical mesalazine is recommended when the inflammation is not limited to the mucosa, but is an inflammation of the cuff. So fecal protein is a good marker to monitor the appearance of inflammation, and also thiopurine are considered very important when we have chronic pouchitis or when the pouchitis are refractory to antibiotic and antibiotic therapy. Other practical points are the association between IBD, especially between ulcerative colitis and sclerosing cholangitis. And in these cases, this patient has to be attentively followed, because there is also a risk of cancer or biliary carcinoma. And in this patient, it's very important to associate the endoscopy of the bowel to liver biopsy. This patient have an increased risk of colorectal carcinoma, but also an increased risk of carcinoma of the of cholangiocarcinoma. The use of ursodeoxycholic acid in this patient remain questionable, And on the other way, on the other vancomycin is always recommended with a high agreement, 90% of agreement.
Scusate,
Prego, ok, I can stop.
saremo pronti dalla sala.
Perfect, we can stop. Interrompi condivisione, ok.
Okay. So we have mobilized the ileum, the mesentery of the ileum. And when you do that, you're supposed to mobilize it up to the uncinate process of the pancreas. That is required in order for the ileum to reach, with this shape, the pelvis, and to have a tension-free anastomosis. Then you pull the small bowel into the pelvis under vision, because it is very important, and it's a known complication of laparoscopy, that the pouch and the bowel is not, you don't have any torsion on the bowel. So that's my pouch. Then you have to decide. So the landmark, as you know, is the symphyx, the pubic symphyx. And if the tip of your pouch reaches the symphyx, you know that it's going to reach a stapled anastomosis. It's not the same if you do an end zone anastomosis. Got plenty of lymph nodes here as well. You know that the length of the pouch should be adapted on the patient. Until a few years ago, the long pouches were preferred. Then we know that the long pouch itself is associated with a complication, which is the mega pouch. And that happens in particular when the upper part of the pouch goes over the sacral bone, so that it creates a sort of a torsion of the upper part of the pouch, and that gives the patient a lot of outlet problems. Electrical? So what I do now, I usually do pouches between 10 and 15 centimeters. We know surgeons who do pouches of 4 or 5 centimeters. That I believe is a bit too little. But also I wouldn't go over 15. You don't really need that big of a pouch. And the pouch usually enlarges after a while. And that is it. Okay, you see that there is still some bowel going over that direction. It's not torted, but it gives us a bit of touch, like that. Yes, exactly. Good, 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 good. Okay, right. So what we do now? Well, we do the same that I think everybody in the world does. So, chapeau. Once we decided the lower limb of the pouch, we open it up. Yes. Hold it like this, exactly on the anti-mesenteric side. Is that okay? Can you see it? And mi dai no, dammi la lineare. No, anzi, dammi la gira. Yeah. Yes. So I usually use a linear stapler, but since we have opened this to show you how this works, and it doesn't work actually, we're gonna use it as well, so we don't waste the stapler. And I suppose it's also better for hemostasis. Open it up for me, please. And a pinza. Dammi una pinza anche te. Dammi una pinza. Okay, it's a bit too small. But we're gonna work our way. Okay. All right. All the tip deposits. Let go this, both of them. So it's very important when you do this to staple on the antimesenteric side, not to make any trauma to the bowel. You have to keep, devi prendere l'intestino qua e tirarlo su dritto, da una parte e dall'altra. Okay, good, like this, exactly. So we usually use a couple of 75 staplers. This is a 60, so we're going to use 3 of them. Also because it is not a 60 millimeter fire, it's usually less, about 5, even less probably. Oramai stiamo usando questi, sì. Ok. Dai anche il manico di un bisturi senza lama. Ok. Dopo, prima So one of the major, not the major, but the most common complications is the bleeding of the pouch. So the pouch is small bowel, it's very well vascularized, which is good. But unfortunately, it can lead to a bleeding of the staple line inside. And that bleeding can be associated with, well, anastomotic leak and the need for, puoi mettere un po' di gel? Un po' di gel. The need for subsequent endoscopic procedures, potentially ischemia, and so on. So my advice would be to use effective staplers in terms of hemostasis. All right. The manico del bisturi? Senza lama, tu hai chiesto il manico del bisturi senza lama? Grazie. Ok. Un'altra per favore. Questo qua, tu devi adesso devi spingere di là. Così va bene sulla fascia antimesenterica. Sì. So this is the second fire. And the staple basically reads the thickness of the tissue, and it adapts the speed of the cutting so that if the tissue is thicker, the cutting takes more time. And that also helps the sealing of the tissues and the hemostasis as well, I suppose. Poi aprito una 29 elettrica. The other decision would be which circular stapler to use for the proper IPAA, so the ileal pouch anal anastomosis. It's a stapled anastomosis, so we have to use a circular stapler. Mi dai il manico del bisturi, per favore?
May I ask how long do you perform the J pouch?
How long is the pouch? It's about, I would say, between 12 and 14 centimeters.
40.
I can measure it.
Because in children, we do 6. Children, I mean, around 10, 12 years, we do 6, 7 centimeters.
That makes sense.
Not more.
Because they get bigger.
Obviously, there is a difference. You are right.
But I mean, I know surgeons, IBD surgeons, who do the same distance for adults as well. So 5, 6 centimeters. I believe that it is probably a bit too low for adults. Mi serve una ciotolina piccola piccola e una siringa d'acqua. L'aspiratore è pronto. Now we're gonna, con l'acqua. We're gonna wash the pouch inside with this. Hold this for me. Okay. So what we do here we wash the pouch. Bene così. Okay. So we see how it inflates. We also perform another one. We wash inside, we see if there is any bleeding. We can actually appreciate the volume of the pouch. I don't know if you see it, but it inflates quite easily. And there is no blood coming out of the pouch. Which is good. Nothing. Bene, lascia pure. Lascia giù. All right. Now we're gonna do the purse thing. Okay, good. Borsa di tabacco. Dai una pen per mettere in coda. Una pinza.
Una pen per la coda e la pinza per lui.
So I do this. I like to do a seromuscular, not to hold too much mucosa inside. I think you don't need it for the anastomosis. And it also keeps the tissue inside the stapler at the minimum thickness. So the staple has the space to close it properly on both stumps. So the rectal stump and the pouch. Qua. Stay qua. Do you have any question from the audience? Non tiratele però, perché se le tirate si chiude e io... Okay. Yeah. Sì. Okay. Taglia qua, 2 chapeau. Due chapeau. Quanto chapeau? Senza danelli. So we open it up in order for the stapler, for the anvil of the staple to accommodate easily dalla sega testina. And we use the chapeau forceps flat put up. Give us some kind of traction. See? Qua. Good. All right. Okay, taglia corto. Perfect. So this is our pouch. Sorry about that. All right. So I'm gonna push it in. quel tappo qua. Guanti 7,5. Sì, entra là però.
Giovanna, there is a change of the field because now we restart with the laparoscopy.
Yes.
And if you want finish.
Yes, I try to go on.
Yes.
I try to go on. Condividi lo schermo. That's my presentation. I try to go down where I was. Just a minute. Okay. Could you see my screen?
Yes.
Okay.
Yes.
So the other complication is the colorectal cancer, where the mechanism is mainly an inflammatory mechanism, and we use to perform the mucosectomy, in my experience, but there are literature that demonstrates that is not a prevention for cancer, so we have to check this patient by endoscopy. Another argument that I want to put in the discussion is the risk of Clostridium difficile infection in children and adolescents. This is a very nice systematic review, and it seems that this risk is augmented if in patients who use 5 ASA and who have an active disease. So we have to look for Clostridium difficile infection in this patient. And speaking about our terrible case of ulcerative colitis, he was at the beginning positive for Clostridium. So then I want to move to the complication in perianal Crohn disease. These were the old treatment with cetons. Now we know that we prefer to use mesenchymal cells therapy. There was a case of Crohn disease that we treated with this therapy, and we obtained a recovery. But I have to say that 3-4 months later, he had a recurrence. So when we look to the literature, especially to the paper was presented by Carlo Ferlini this morning, and we know that the follow-up of this patient is a short follow-up, we have to look to medium time follow-up, because in this case, the recurrence was terrible. Instead, the biological therapy, and this patient underwent to surgical treatment, not made by us, but by a general surgeon of the perineal Crohn in the old manner. So this is a new frontier, but this patient has to be followed for a long time. I want to move to the complication as to the slide that Professor Poggioli showed this morning, because I found very interesting. First, is the importance of experience, and so we know that in pediatrics, the experience in IBD can be a tremendous experience as the adult center can have. But if we work, as you can do in Bologna, and as I have done in Milan and also in Pavia, with general surgeons who are expert in this procedure, we can also obtain good results, but we have to consider at least 20 cases a year. And looking to the complication, septic complication due to anastomotic fistula are very bad complication. I have to say that this is generally due to the, to the bad vascularization, vascular supply of the pouch. And so in this case, I think it's better to think when we have difficult case with not so long meso, because sometimes the meso is quite thick in this patient, to do a protective ileostomy. That means a 3-stage procedure. Regarding how to treat, Professor Poggioli presented the endosponge. I had some experience of endosponge showed by our general surgeon, and I have to say that it works really, it seems to work better than other solutions. So we also are in favor of this kind of device. And looking to the pre-pouch ileitis, this is a terrible complication. I had no experience. And as I have no experience about the mega pouch as it described today, I have to say that I have learned by Annie Cohen, who had the biggest published experience in ulcerative colitis, that if you do a very short pouch, they didn't observe in the Ann Arbor series this kind of complication. But I think we have to look also to the follow-up of these patients, and maybe we have not enough information about the follow-up in an adult age. I have finished, and I am pleased to give the floor to Tommaso Gargano if he has to show some complicated cases.
Thank you, Professoressa Ricci Petitoni. One moment that I...
Voglio finire la mia condivisione. Finita? Okay.
I'm trying to share my screen. Okay. Okay. You see my screen?
Yes.
Okay.
Well.
Thank you. Thank you. Good afternoon, everyone. I'm going to present two pluri-complicated cases extrapolated from our experience in the surgery of IBD. So the first one is to integrate what Dr. Dimitri said this morning during the first question time, because this is a case characterized by a lot of adverse events. This is a case of Bianca. She was 11 years old girl, admitted to the pediatric department for acute abdomen due to suspicion of acute appendicitis. And we performed after the preoperative workup consisted of ultrasound CT scan that suggested for acute appendicitis. We performed an urgent laparoscopy that we found cecum inflammation with an appendix with thickened with thickened wall and pale wall. There was a fluid collection in Douglas space and the omentum to cover the cecum. So we performed the appendectomy. So unfortunately, after 2 days, Bianca required a urgent longitudinal laparotomy for the peritonitis due to a cecum perforation. We found a right colon suffering and very inflamed, signs suggestive for IBD. In fact, we performed the right hemicolectomy from middle transverse colon to terminal hilum, and with a derivative terminal hyostomy with the suturing of transverse colonic stump. The histological confirmed the suspicion of IBD, in particular to allow to diagnose the Crohn's disease. And Bianca started the medical therapy. But after 20 days, Bianca presented a partial descent of wound, probably this complication for the failure of proper wound healing due to the medical therapy of the Crohn's disease due to high dose corticosteroids, the prednisone, and the immunomodulator drugs. After 2 months, we perform a coloscopy that showed an inflammation.
Scusate, dalla sala, siamo pronti per la parte finale del pouch.
Ok.
Scusa Tommaso.
Ok,
Hello.
un attimo la condivisione. Ok, vai.
So now you can see the stapler, the transanal stapler. Inside the rectal stump, we got a lot of traction here. But the rectal stump is actually quite short. It's basically 1 phalanx of my finger. Yeah, a bit of counter traction, only with the tip, not the tip. Yeah, no, the tip. Okay, well, good, very good. Okay. Now I'm at the perineal area, so this is a very delicate part of the procedure. If anything happens, the procedure becomes something completely different. So I believe that the first operator should be down to move the circular stapler. And I have my assistant Giacomo Calini, who is a very skilled surgeon, despite what you're seeing now. If the Joan arrives like that, it means that you are in the wrong trocar. So that trocar allows you to be more perpendicular to the anvil, because the anvil is quite tricky sometimes, okay? So you have to hold it from the base of the anvil, like this. And you have to stay perpendicular.
RV.
Okay, move the pouch before you grasp. Okay,
Yeah,
move
RV.
the pouch back. Okay, good, good, good. Okay, good. We'll go back a bit. Do all that. Stay still. L'altra pinza via. Vai. Good. Okay, we heard the click. Now Giacomo is gonna hold the pouch straight. Doesn't really matter, you know. There are a lot. We usually keep the mesentery downwards, so towards the sacrum. But a lot of people do exactly the opposite. Get closer a bit. We need to see the pelvis now. Okay, good. Move the vagina out of my way, please. Everything out of my way. Okay, on the other side as well. Anche nell'altra parte, Giacomo. Lascia pure la pouch. All right. So let's close this. Don't force it to stay where you want. It goes where it likes, okay? And that's okay. It means that the tension is lower if the pouch is sitting like this. So always close it under vision. Be careful about the vagina. You see that the vagina is just there. This is an electronic stapler, so we don't have to close the angle. It just have to push a button. Hopefully it's gonna work. And the advantage is that you see it doesn't really move, because when you use the manual staplers, there is a lot of movements over the staple line, which is not ideal. Okay, all this, no, it's fine. I check the rings, which are okay. Both rings are okay. Now, Giacomo is gonna put some water in the pelvis. And we'll do the okay, ready? So no bubbles. Good. We always put a drain in the pelvis. We remove it after 3 or 4 days, so just before the patient goes home. And we also put a Foley catheter, not inflated, obviously. We cut the balloon inside the pouch. It's important to put it there because if you have an early bleeding, you can see it earlier. And the pouch, especially in the first day or two, doesn't get into doesn't get into tension, which is not ideal for the pouch. Okay.
May I? There is a question from the floor.
Yes.
How do you prevent the bowel twisting?
When you put the pouch downwards towards the pelvis and you do it laparoscopically before you create the pouch, when you move the bowel there, you have to make sure that all the small bowel is on the left side of the abdomen. And you can see the mesentery of the terminal ileum straight from the duodenum to the pouch. If you do that, you're sure that no matter where the bowel goes, the pouch is straight. If you don't do that, what happened to me on my first laparoscopic pouch, I mounted the pouch twisted 360 degrees. And after 2 or 3 years, I had to reoperate on the patient to resect the bowel, untwist it, and re-anastomose it. Luckily, I didn't have to redo the pouch, but still it's a complication that we should avoid. So you always have to check the orientation of the mesentery of the terminal ileum and be super sure, triple check that the bowel is in the correct position. Posso avere, Giulio?
Thank you.
Serve dell'acqua, scusa. Sì. So I'm washing the pouch just to make sure
We have another question from the audience.
Yes.
We can prevent the rectal prolapse.
The rectal prolapse. Well, the most important thing I think is to keep a short rectal stump. If you do that, you prevent a lot of complications. You prevent cophitis, which can happen, obviously. But as you know, cophitis has become a serious complication after the introduction of stapled anastomosis, which means that probably what happens is that we leave some diseased mucosa there, and you can have that complication. So the major thing is to keep a very short rectal stump. Don't damage the sphincters. So when you do the dissection, you have to keep away from the levator ani so that the patient has a good continence. And if you do that, we don't see many pouch prolapses, I have to say.
Thank you. There is any question from the audience. Thank you, Professor Rottoli, for the wonderful procedure. It's very clear and is very didactic.
It's been a pleasure.
Now we complete the presentation, Tommaso, with the complication. Thank you, Professor Rottoli. Bye.
Thank you all.
Thank
Have
you.
a nice night.
Thank you.
Thank you, Professor. So I screen, okay. You see my screen?
Yes.
Okay.
Yes, yes.
Thank you, thank you. So after 2 months, we perform a coloscopy that showed an inflammatory regenerative pseudopolypoid lesions at 2 sutured transversus colon stump. So we performed the serial biopsies that confirmed the Crohn's disease. But 4 months later, for a bleeding persistent abdominal pain, we reperformed a coloscopy that showed an inflammatory and ulcerative lesions. So for a severe disease activity for the Crohn's disease, we perform a residual colectomy sparing the rectal stump and with the helium rectal anastomosis. So 2 months later, unfortunately, Bianca requires another operation for the intestinal occlusion for adhesion. You can see the visceral adhesions and the visceroparietal adhesions. So we performed the dialysis of the adhesions too. After 2 years, fortunately, during the follow-up endoscopic evaluation, Bianca has had a good clinical endoscopic improvement, and you can see in also after 4 years during the follow-up, she had a clinical improvement, and the condition is well managed by medical therapists. In literature regarding the correlation procedure, appendectomy, and Crohn's disease, say that the changes in the intestinal microbiome induced by appendectomy may influence the occurrence of Crohn's disease. The surgical stress can trigger on the onset of Crohn's disease and negatively influences the postoperative course. The appendectomy increases so the risk of Crohn's disease and worsens the prognosis of the pathologist. The second case is the case of Martina. She was a 1-year-old patient affected by a complete androgen insensitivity syndrome. She had 46XY with a female phenotype. She underwent at 8 months of age a bilateral gonadectomy to prevent masculinization at puberty and to prevent the rare case of malignancy. And she underwent at 2 years of age a vaginal replacement by colosigmoid vaginoplasty and complementary appendectomy. And she underwent at 10 years old a seriated and several osteoplasty for the complicated stenosis of the vaginal ostium with followed calibration. For recurrent inflammation of the graft with ulcers, granuloma, and ostium strictures. So you can see the granuloma in vaginal ostium, the stenosis of the ostium, and the osteoplasty with the calibration. During this procedure, we perform always the endoscopy of the graft, and you can see the inflammatory mucosa with ulcers and the bleeding inside. We performed also a rectoscopy for rectal bleeding that you can see the mucosa that appear edematosa, ulcerated, and hemorrhagic. So we performed a biopsies that that confirmed the ulcerative colitis, the condition of ulcerative colitis. So we performed to Martina a total colectomy. You can see the procedure with a terminal derivative ileostomy. So we spare about 5-7 centimeters of rectum because it's very, very adherent to the neovagina, to the graft. But after 3 months for a persistent bleeding due to probably to active colitis, we required a rectal residual resection. And you can see the resection of the rectal stump of 7 with by transanal ileum anus anastomosis by circular stapler in transanal circular stapler. Then in June 2007 we required Martina required a new osteoplasty for restenosis of the ostium, the calibration, and in February 2010, the fusion of the ostium with the calibration, probably for the inflammation, continued inflammation due to the neovagina involved of ulcerative colitis. So you can see during the osteoplasty, the vaginoplasty, the endoscopy of the vaginoscopy, sorry, the endoscopy of the graft that showed edematous and hemorrhagic mucosa with sporadic ulceration. And during the endoscopic follow-up, you can see the disease that continues in the neovagina and in distal ileum. But now we administrate the medical topic therapy for the maintenance of the remission of the condition with mesalazine in the graft and in the ileum. The literature said report the similar cases to our. So you can see report a case of a 8-year-old girl who, as an infant, underwent vaginoplasty using sigmoid colon for persistent cloaca in this case. And she developed a fulminant colitis that also affected the colonic neovagina 2 years after her reconstruction. So we know the potential long-term consequence using a colonic conduit for vaginal replacement. So the patient present in this other paper presented with a history of bloody mucoid vaginal discharge, abdominal pain, bloody diarrhea, and weight loss. The patient developed ulcerative colitis refractory to medical therapy with simultaneous condition involvement of sigmoid or neovagina as our case. Thank you very much for our attention.
Thank you very much, Tommaso. This is very particularly the case. And I want this question from the floor. Is it better ilioanal or iliorectal anastomosis? Dear discussant, what is your opinion? Giovanna and Massimo. The question is Fadi Dalaghi ask you.
Obviously, it's better ilioanal because if you leave a lot of rectal tissue, you have a major risk of cancer. But when we speak about ilioanal, you have to consider, I try to show, if I am able, just a slide of my presentation of today that I stopped it, just one slide, if I am able to find, which is a slide from Com, famous expert in IBD, adult IBD. Okay, I try to share this slide, just a minute, just to know. Okay. Okay, could you see the slides?
Yes.
Yes. So when we speak about ileoanal anastomosis, we have to consider that what we are speaking about. So we have to consider anal tissue, anal transitional zone, the column, and then the anastomosis will be at that level, at the same level, almost the same that we do for Hirschsprung disease in order to assure the better control of the continence. So we have to know very well the anatomy before speaking about rectal or anal. Obviously, if you do a knife Griffin procedure, as Professor Rottoli did today in a fantastic way, you are going a little bit up, because and you leave about 2 centimeters of rectal wall. If you do a mucosectomy, obviously you can go here, just at the level of just above the column. So the difference not so big, but what I want to say that it's very important to use the same language.
Thank you, Giovanna. Massimo.
Giovanna, leave this beautiful slide. And
okay.
Obviously, I agree with you. The answer is that at the beginning, we were doing the mucosectomy, taking the mucosectomy till 1 centimeter above the columnar cuff. That was the point where we were making the anastomosis, the straight anastomosis between ileum and rectum. Then we decided that this was very bad for the child because we had a lot of stools, and we start all over the world to do the a pouch in some way. At the very end, the J pouch became the most popular, but the knife Griffin, as we have seen today, I've done it many times, is a fantastic is a fantastic procedure, but not only you must be careful and be at the line where you have the flag, there must be done the anastomosis, but then you must consider that using the stapler, the circular stapler, there is a piece, a ring, a circular ring of rectal mucosa that disappear to your possibility of surveillance because it's inside. Because when we use the circular stapler, there is a piece of mucosa that go inside. So it's obviously it's better, in my opinion, today iliorectal. That means very low. Rectal means very low on the rectum. But the surveillance is a very important issue. Pouchitis is a very important issue. By the way, we have this kind of ghost, of phantom, of the possibility of malignancy on the pouch. If I were 30 years younger, I would like to do a survey between all our Italian patients that have done a knife Griffin and see how many malignancy we have seen. But anyway, the problem is that if you leave a little bit of rectum, you have a better continence. That's sure. And that's it.
Thank you very much, Massimo. And if there is
Evidence is made especially by the sphincter and the muscles. So if you do a mucosectomy, you will maintain obviously all the muscular structure, but you have to go up to the column.
So down in the pelvis, so close to the columnar cuff doing the mucosectomy. I like that operation so much, even if sometimes it's very difficult if there is a hard inflammation. But the result were very bad.
Very difficult, but I want, if I am able, to show you just this article. This is a very recent article, initial experience with transanal protectomy in children. So there are also some interesting technical details. They used to perform, as I do, the single incision colectomy, and then they go transanally up to the pectineal line to perform the protectomy. It's a nice article that I invite you to look on.
Yeah.
There are a few cases, 7 cases. So
Giovanni, we have to stop reading all these new articles.
okay, okay. Okay.
Mario, may I close the session?
Yes, it's arrived the moment because it's late, but I think it's very interesting.
24 minutes after 6, but I mean that I think that has been a very interesting meeting, a very interesting and stimulating session. Inflammatory bowel disease is a pathology with which the pediatric surgeon, more than the gastroenterologist, have to face with, and it has been very nice, very interesting to compare our ideas with the adult surgeon idea. And for this, I thank you, Mario, and thanks Professor Gianchetti and all the team of the adult surgeons. And okay, we will meet the next
Yes.
date that is on July. Is that right?
Yes, the next meeting is July 10, and the topics is the bariatric surgery in children.
Okay.
It's another challenge, this.
Okay, okay. But we don't close without remembering everyone that the UPSA meeting in Bologna and the Pediatric Colorectal Club in Bologna will be held from
I think it's 20 days, because we start in 10 of June, 10 and 11 is the Colorectal Club, and 12, 30, 40, and 15 is the HUPSA meeting with the precongressal course, and there is also another course of hypospadia with lab surgery. I hope that if it's possible to come in Bologna, I hope that is a good weather, the good weather, and I hope also there is the good food.
Yeah. Okay, Mario, thanks so much. Thanks so much.
Bye-bye.
Giovanna.
Bye-bye. Thank you very much.
Thanks so much.
Thank you, Mario. Thank you to everyone.
Bye-bye. Dr. Gargano, bye-bye.
Bye-bye. Thank you.
Bye.